Recording in progress. Good morning, Marcia. Can we start? Are we a quorum?
Good morning, Chairperson. Good morning, colleagues. Yes, Chair, we are quorum. We may start.
Good morning, honorable members. Good morning to the support staff, to the honorable MECs, as well as the teams from the different provincial departments. A very good morning to you all. And I just want to welcome each and everyone to the Select Committee meeting this morning. And honorable members, we are here to get the briefings from the last 3 provincial departments. So to the MECs and the provincial departments teams, we are going to allocate 30 minutes to each department to give us a presentation so that we can manage time. So honorable members, Marcia, can you please flight the agenda?
Sorry, before that, Chairperson, I greet you, but I wanted to apologize for something.
Yes.
There is a person who's registered Samsung SMS938B. And there is this tendency, always when our committee is sitting, some of the people, they don't want to show themselves. Who's this person?
Can that person please identify him or herself so that we can go on with the meeting? If not, can we then ask the support staff to please rename that person's gadget? Is that fine, Honorable Sibande?
Yes, I agree. But if he doesn't name himself or herself, what must we do?
Then
We can't be bogged down by an individual.
Yes, the support staff must take him then out of the meeting if he don't rename his gadget. Honorable members, the agenda is in front of us. Can I get a mover to adopt the agenda? Honorable members, I can't see your hands, so you can shout out.
Chairperson,
Yes, Honorable Adrianza.
I move to adopt the agenda.
Thank you very much, Honorable Adrianza. Can I get a seconder?
Seconded Chair Makifeni.
Thank you, Honorable Fanny. So we move over to the apologies. Marcial, can you give us the apologies?
Again, good morning, Chairperson, members, and delegates. Chairperson, we haven't received any apologies, only to say that the Western Cape MEC might be a bit late due to a prior engagement. Thank you, Chair.
Thank you very much, Marcial. Can I get a move for the adoption of the apology? There's no apology, so there is no need for adoption of the apologies. Honorable members, we are now. Marcial, can you please flight the agenda again? Honorable members, we heard about the member of our committee, Honorable Ngobo, that passed away. I just want us to have a moment of silence. Please, members. Thank you very much. Our deepest condolences to the family and friends of Honorable Ngobo. May her soul rest in peace. I thank you. Just a moment, honorable members. Let me just get it. So we move over to the Department of the Eastern Cape. Honorable MEC, over to you for the briefing.
Good morning, Chair, and to the honorable members. This is MEC Kappa from the Eastern Cape. I will just firstly would like to apologize because there's been a prior arrangement in terms of what is happening in the disaster in Umtata. So I'm in Umtata. The signal is not good, as well as the background as well. So I want to apologize. And I would therefore request on behalf of the department to request the HOD to do a presentation if you allow us to do so, Chair. Thank you very much.
You can proceed, Honorable MEC, with the DG.
HOD, can you please quickly...
HOD, thank you.
Good morning, honourable members, and good morning to the colleagues on the platform. If I could just ask that the presentation be uploaded. Thank you very much. May I put my camera off just to preserve the bandwidth, Honourable Chair?
You can do so.
Thank you, ma'am. Honourable Chair, is it visible? I'm going to put it into presentation mode.
It's visible, but you must put it in presentation mode.
Thank you, Honourable Chair. If I may proceed, it's to present the readiness to implement HPRS and the action plan to address the findings of AGSA 2324. So starting just with the readiness to implement HPRS. As honourable members are aware, in the Eastern Cape, we have adopted the HPRS as part of the NHI implementation. Our CUP site is in Musa Hill Subdistrict. There we have 100% implementation. We do have challenges being a rural province. Those challenges in the main are related to connectivity issues, the budget limitations that impact our ICT infrastructure, and just technical support when our facilities encounter challenges. Nonetheless, we have trained 9 technicians recently to support this program. We've made some progress in that we've installed HPRS at 764 of our facilities. That's a 98% coverage. In addition, we've been migrating these facilities to the new version. So 501 are currently on the new version. We have registered over 8 million users on the system with about 29.99 visits recorded since we started installing HPRS at the system. Our AGSA raised 2 issues in relation to the 23-24 audit. The one was not having adequate controls for logging when we have problems. And the second one is the interfacing with other systems to make sure we optimally utilize HPRS. I will reflect on what we've done to deal with those issues. So this is just demonstrating how in the last 6 months, we've started improving the synchronization of facilities, and yet we believe that there's still room to improve that each month we connect more consistently so that the information is up to date on HPRS. This is just demonstrating our district distribution each month, and where we identify problems, we go into then support them. Honourable members, this shows again how we have moved over to 501 facilities on the new version by district. And then this shows our registrations on HPRS versus the total number of visits. I think just the point we were making here is that the number of patients actually exceeds the number of the population. So we have about 7.2 million people in the Eastern Cape, of whom 90% is dependent on the public sector. So one would expect around 6.5 million registered people. And this is that when the system is down, we have connectivity issues or load shedding during those periods, our staff can't upload to the system to go or connect to the system to be able to check the information. And so they create a new number and that results in duplicates. But the National Department of Health does clean up the data from time to time to remove those duplications. Honourable members, we also have our HPRS linked to NHLS. These are the total number of sites where we've done reviews, where we've identified that facilities are eligible to migrate and that they've got the relevant hardware that is adequately configured. We then are also linking to the laboratory services system. This shows, honourable members, where we've done assessments beyond our site, our NHI pilot site, to the other districts now, and we are again migrating and moving to NHLS linkages to those facilities that have been identified as potentially eligible, and we've already delivered 228 sites with hardware that they need to be configured. Honourable members, we're just showing that despite us rolling out the devices to 764 facilities, in April of 2025, only 606 of our facilities remained actively connected and operational. So there were about 158 facilities that were not active despite us having capacitated them. And there's a number of reasons why these facilities have, why we have a few facilities not active. This slide demonstrates what these challenges are. In the main, it's connectivity. So there's poor connectivity, especially in our rural areas. We do have facilities covered by broadband, where we don't have the broadband infrastructure as a province yet. We're using LTE routers and data bundles. And we've recently awarded a tender for networks for that the last mile connection of the facility into broadband infrastructure where it exists. But we do have areas, because of the rurality, where the providers don't even have signal cover. Then, honourable members, our other challenges to support when facilities have challenges. We know that Health Systems Trust has withdrawn their technical support, and that did cause some of our facilities to have challenges and not come back onto the system. But with the training of our 9 technicians at the beginning of this year, we are now starting to provide that kind of support to our facilities. And then one of our other big challenge is with our budget constraints, and especially with the PEPFAR fund threatening the data captures to ensure that we're capturing information on HPRS is a challenge. So we're busy with the resource plan, development of a resource plan at the moment. Honourable members, just with the broadband rollout, the department has a total number of 1,060 facilities, so that's clinical as well as administrative facilities, and 840 of these were connected through the copper network. Our broadband project started with the first site connected in March of 2021. We identified 598 of the 841 sites were prioritized to be part of the initial rollout of the province. We have 403 sites connected on broadband from March 2021 to March 2024. And in the last financial year, we added 74 more sites, bringing our total to 477 sites connected to the broadband network. In this financial year, as stipulated in our MEC's policy speech, our MEC has prioritized the allocation of 29 million rand for the land infrastructure so that we can optimally utilize broadband where there is infrastructure in our province. We are targeting to connect 50 additional primary healthcare clinics and 10 hospitals through this system. Now, honourable members, we do have challenges. The broadband project was halted in August of 2024. It is coordinated and run by our Office of the Premier, and there were budgetary challenges. And so we had a site deficit of 121 of the 598 that we had earmarked originally for rollout that were temporarily halted. The broadband project is back on site. As I was indicating earlier, where we don't have broadband, we are using LTE routers at the balance of the sites to try and have some connectivity. Moving on to the AGSA findings of 23-24 in relation to the HPRS, it was essentially 2 findings. The one is that we didn't have a formal logging system for the facilities to log when they had problems or complaints, and so this pointed to a control weakness. And then secondly, that HPRS was not interfacing with other systems. So the recommendation was that there be a formal process and that HPRS interfaces with other systems. Honourable members, as we are June of 2025, the National Department of Health has confirmed that there is a formal call logging and support system, and there's a process that we adhere to. So we formally log, we get a ticket, and they do one of two things. They either assist us and fix it remotely, or they deploy the technicians that we now have in the field to try and support that infrastructure. Our technicians have been accredited and are able to perform these kinds of functions. And then, honourable members, with respect to interfacing, so the National Department has indicated that the District Health Information System does not deal with individual data. So that's the reason why it doesn't link in. And then on tier.nec and EDI, it's going to be phased out. So there's no interface with HPRS. But in our province, honourable members, we have our own electronic health management system called HMS2 that we implement at our hospitals. And there is a one-directional link between HPRS and HPM and HMS2. So when our admin and reception log on, they go into HPRS, they have a look at it, they draw the number into our system, and we allocate that unique patient identifier to our patient records. We are advocating that there be a two-way link so that we can also put demographic information into HPRS where they don't have that patient registered on their system. And then, honourable members, this just shows how, as we rolled out HMS2, the integration with HPRS was a part of that journey, so that at our hospitals where we have the HMS2 system, electronic patient record system, it does in fact integrate with the other systems, including HPRS. Honourable members, because we've made this, the HMS2 is our own in-house developed electronic patient system. We own the IP. It's been designed and developed by clinicians and administrators for the healthcare system. We therefore do not spend any money on licensing and the development of the system. And this has allowed us to utilize that money, the savings on software, for ICT infrastructure and for our people. And so, honourable members, we just demonstrate in the slide what we have focused our budgets on and what we've been developing. The last row just shows that we've got about 5.5 million people registered on our electronic patient record system, and the various statistics of where they've attended our OPDs and attended our inpatient visits. We've also showed the investment in our hardware infrastructure, laptops, as well as server infrastructure, etc. Honourable members, for our overall e-health project, because HPRS is part of the e-health program, between 22-23 and the 24-25 year, we've invested 159 million rand across 50 different healthcare facilities, and our electronic patient record system also has modules on revenue collection, as well as the medico-legal registry. Our primary focus has just been to destabilize our ICT networks and make sure that we can replace our equipment and peripheral devices to enable e-health investments and activation. So, honourable members, just to conclude this first part, we are adopting HPRS. We do have some challenges with respect to internet connectivity, but as we indicated through the OTP, the rollout of broadband is allowing more of our facilities to come online, and where we don't have broadband infrastructure from the provider, then we are covering that with LTE routers and data bundles. Not ideal, but it does provide a redundancy solution. And we now have the 9 technicians providing support as we're trying to ramp up HPRS implementation. Honourable members, if I can then move to part B, our action plan to address findings of the AGSA 23-2024. As we can see year on year, we've always had a qualified audit opinion. And this was essentially because of a qualification on the area of contingent liabilities. In the 22 year, it was because of measurement of contingent liabilities, with the rest of our audit, the main audit, unqualified. And in 23-24, again, we had a qualification only with contingent liabilities with its opening balance. We reduced our findings from 15 to 10 findings. With respect to the AOPO, here we moved from a disclaimer in Program 4 to a qualification, and Program 2 also was a qualification in our information. Honourable members, just looking at contingent liability, associated in the main with medico-legal settlements. We can see that there's been a systematic decrease in the contingent liability from its peak of 38.6 billion rand in 2021 to 22.234 declared it as our closing balance at the end of 24-25. We've invested a lot of time in an accounting policy on how to deal with the various stages of a medico-legal claim. We've also focused teams on trying to have a reliable and accurate e-liability register. It's one of the modules on HMS2. So every facility that has HMS2 has access to the e-liability module and can see what its exposure is with respect to PAHIA and medico-legal claims. And then we've also focused and had task teams at the clinical domains, making sure that we classify the kind of clinical claim correctly, because that has a bearing on the measurement of your contingent liability. So a lot of effort has gone into this. Honourable members, just with respect to the Audit 24-25 process, because we've obviously been implementing our audit improvement plan in the 24-25 year to address the 23-24 year issues. We have regular sittings of our audit working groups and audit steer committees. We communicate those dates in advance to promote attendance at those facilities. We kicked off our audits in January, 15th of January, we signed off and circulated a communication of the commencement of the audit in January, and the engagement letter was also submitted to the AGSA. We had our first kickoff meeting on the 24th of January, and it has been supported by our national department as they are behind us and advising on our pursuit of the unqualified audit opinion. We also met the new AGSA team in February to onboard them and make sure that there's a consistent understanding of issues pertaining to our qualification matter and the register and how it works. Honourable members, this is of significance and importance to our province, and so we also have to report to our Cabinet Budget Committee as well as Provincial Treasury supporting us. Everyone is behind us addressing this final matter of qualification in pursuit of an unqualified opinion. In terms of monitoring the audit implementation, we have had 13 working groups already up till June. We have a register of all work group resolutions and make sure we follow up on those. And then we have a register for all RFIs and COFs to make sure that we submit within the time prescribed by the AGSA. Our Honourable MEC also exercises political oversight, and so we've had 2 meetings of our MEC with the AGSA, as well as every Tuesday as an executive management team, we account to our MEC on progress with implementing the audit improvement plan. We've written letters where our individual DDGs and GMs failed to submit or they were late with their submissions to make sure that we submit on time and that we address these issues with the AG. And so we track, for confidentiality's sake, I've just put in the initials, not the actual names of the officials, but we've written to 15 of our managers, senior managers. They have responded and we've held them to account, and we're following up the outstanding 2 letters. Honourable members, given that our qualification has been on the issue of contingent liability, we've spent a lot of focus on addressing this matter. We've restated our register and we submitted that on the 7th of February already to get an interim audit to make sure that that which we believe we've addressed is in fact tested. We also updated our policy on the medico-legal management that was signed and submitted with our annual financial statements. And it was also, again, addressing issues of the 23-24 year. We utilized those issues and updated the policy so that there was alignment, and we were now addressing some of the control weaknesses that had been identified. As we were saying, every Tuesday, there's a meeting where the contingent liability register and the projects around that register is discussed under the chairmanship of a designated audit committee member. Our internal financial control, 2 managers have been allocated to work with our legal services team to make sure we deal with those documents where the courts have given us that the court documents are faint, their stamps are faint, or there may be incomplete documentation. That's a project where we work with the courts to try and retrieve those documents, and we've agreed with the AGSA on how we deal with that matter in its declaration of our financial statements. We've also made sure that our staff are available and no one is allowed to take leave without authorization from my office to ensure that everyone is available to respond to the audit in this year. And as I said, we did a categorization project to make sure that our measurement for the contingent liabilities can be as accurate as possible. The department has engaged the registrars of the 3 high courts, and that's to assist us in fast-tracking the Rule 37B. These are our dormant claims where we're asking the courts to confirm that they're dormant, and they can then be removed from our register of contingent liabilities, and to help us with the stamps that are faint as well as incomplete documentation. Honourable members, our interim findings, there were no material findings of the interim audit when we submitted those statements on the 7th of February. At the moment, the audit is still underway with respect to the contingent liabilities. Touch wood, thus far, there's no difficulty with the submissions, and we haven't had any major issues reported by the AGSA thus far. And then with respect to our AOPO, this is essentially around our record management. The sector audits also are being conducted this week, and we're busy with the AOPO. The feedback from the Auditor-General thus far is that there have been no major issues that have arisen whilst in the field. Honourable members, our audit also focuses on the areas with respect to the material irregularities, and our material irregularities in the main are related to our COE, our cost of employment, and here the journals for correcting employee costs is work that we are currently busy with at the moment. We do regard it as an area of potential high risk, and so we are paying close attention to it. And then, honourable members, I won't go through 10 to 13, which just lists the number of COFs that have been issued. All COFs have to be reviewed by our DDGs to ensure that the right degree of seniority is reviewing our submissions and that the quality of the submissions are adequate and complete. This, honourable members, just summarises that of the RFIs, 90% of the 157 have already been responded to, 13 are not yet due. And then with respect to our COF, 68% have been submitted, but 27%, 6 of them are not yet due, and we're pursuing the outstanding ones where the AG has asked for additional information and asked for an improved enhancement of our responses. Our challenges and the actions taken, honourable members, relate, as I said, to material irregularities. So we are focusing on that and supporting our HR and corporate services teams. They have in fact submitted their progress report with the supporting documentation to demonstrate that we're addressing the findings and addressing the systems improvements. And then, as I was saying, with respect to non-submission of information, although there have been very few, we have issued a circular for warning our teams that there will be audits. If there are any audit inefficiencies, we will be recovering that from our staff. The few that we have identified, the 15 letters that we've written to, as we indicated, if it does result in an audit inefficiency, then we will claim that back. Our challenge in the medico-legal unit was the shortage of staff. We had a huge budget pressure last year on cost of employees. We were unable to renew certain contracts, but our Honourable MEC did make the decision to extend contracts for those contract workers working in the unit, working on the contingent liability register itself. And we've also provided additional interns to the legal services unit to assist them with the administration of the files. Thank you, honourable members, for the opportunity to present our action plan and our readiness for HPRS implementation. Thank you.
Thank you very much, HOD, for the presentation. We now move over to the Free State. Honourable MEC, over to you.
Thank you, Honourable Chair. Greetings to all the honourable members. I'm not sure, Chair, if we can just shoot or are there other things that we must deal with. Apologies that I joined a little bit late when the meeting had already started.
Now, you can just shoot MEC, but we will request all presenters and the MECs just to put on your video for just a second or 5 seconds so that we as the committee can be familiar with the faces and the names. Thank you very much, MEC.
Honourable Chair, I That's my face on the screen there. I think I can then switch it off so that other team members can then appear on the screen. But I think we'll do that as and when they start presenting. Honorable members, honorable chair, all the respective officials that are in the meeting, we take this opportunity as Free State Department of Health to welcome the opportunity to come and present before you. And we observe that we have been allocated quite a very limited time. As a result, there will not be a preamble and a background and an introduction. I'll just hand over to the team to make a presentation. The HOD, Memas Chabasi Singh, is not well today, but she is in the meeting. I will request her to just but the presentations will then be led by with the topics that we're dealing with today. But I just wanted to check with the Honorable Chair if that will be permissible.
You can proceed in that way, Honorable MEC.
Thank you very much, Honorable Member. We'll start first with Ntate Bandile Ndombela, who will present to us the HPRS system and the progress that we have made in line with the directive. And immediately thereafter, Ntate Chris Elefthreou will then come in and present the issues about the audit. And if there's anything that is left, the CFO will come in and then the HOD will just come in just finally. Ntate Bandile, please go ahead with the permission of the chair.
Thank you very much, MC. Thank you very much, Chairperson, and good morning to the honorable members. I hope you can see my face, Honorable Chair.
We can. You may proceed.
Thank you very much. For the purpose of sparing on the bandwidth, Chair, if you permit, I'm going to switch off the camera. Not so much that I do not have my makeup on this morning. My name is Bandile Ntombela. I'm the Director for Information and Communication Technology, and I will be giving a briefing to the committee this morning on our implementation of the health patient registration system in the Free State. Honorable Chair, we started rolling out the HPRS in the Free State as far back as 2014. This is when the NHI pilot sites, the 8 pilot sites across the country were started. We started in our district of Thabo Mofutsanyana. As it is, all of our 253 facilities that are public health facilities, that is, are operating the HPRS system. We have registered to date 3.8 million patients on the system, and that is slightly higher than our population, and that deficit can be attributed to the number of people that just visit our facilities to access healthcare, as well as some of the foreign nationals that reside in the Lesotho area, to be specific. On the HPRS, across all of the facilities, across the 5 districts that we have in the province, we've registered 37.4 million visits. And some of the key success factors that have attributed to the success of HPRS implementation in the Free State is the universal availability of connectivity, facility-based IT network.
Bandile, you disappeared now, so I don't know what is happening now. Honorable members, can you hear him? Because I can't.
Can you hear me?
Hi, Chairperson.
Can you hear me, Chairperson?
We lost you.
Am I
The key success factors, there we lost you.
okay, great. Am I audible now?
Yes, you are now.
Sincerest apologies, Chair. Yes, we were saying our key success factors can be attributed to the connectivity at all of our facilities, hospitals and clinic, where we're using SETA as well as mobile network operators. We have district and facility-based IT technicians that provide direct support to our facilities to enable them to consistently use HPRS in a prudent fashion. We provide oversight and technical support from head office, where on a monthly basis, we pull reports that show which of our facilities are offline and online insofar as HPRS is concerned, given its importance. There's very strong and political commitment from the province. And this is a message that we consistently share through our budget vote speeches. And then lastly, the National Department of Health has been most helpful in providing computers, tablets and printers, and some of the ancillary accessories that are required to keep HPRS operating at our facilities. On this slide, we demonstrate how often the facilities themselves synchronize, and this is linking up with the national database for HPRS. Chairperson, 249 of our 253 facilities just in the last month were online. Now, the importance here is that if at all we lose track of having our facilities online, it means we are not quite able to track the movement of patients from facility to facility across the different provinces. And that's why it's so important to always have HPRS online, because the intent is for us to track the movement of our patients across all of the health facilities in the country. It is just two delinquent facilities that we're not able to synchronize, and that's purely because they currently are not operating. One is in the Fezile Dabi district in Kronstadt, which is temporarily closed due to renovations, and the other facility is a container facility that has since closed down in 2024. We will be working with our information management team to probably remove that facility off the HPRS database. To re-emphasize the point we made earlier, we already have about 3.86 million patients that have registered on our HPRS, and the deficit really, because the Free State is just slightly below a 3 million population, that deficit is attributed to some of the patients that are moving from different provinces to access our health services. The honorable members would know that we border Lesotho, and we do provide health services to some of the Basotho nationals in some parts of our districts, especially in Thabo Mfutsanyana. In addition to that, the National Department of Health does do data cleanup exercise on a recurring basis, and that exercise is called data deduplication. It is because of that we've registered over 37 million visits on the HPRS at all of our 253 facilities. We're running a very updated version of the HPRS, as it were, over the years. The HPRS continues to be updated to bring it up to speed, as well as close some of the emerging risks such as cybersecurity. And at 243 of our facilities, we're running the new version of HPRS. Now, what this has also allowed us to do is that we one of the first provinces that are finalizing the linking of the HPRS with the National Department of Home Affairs, where we are able to validate users that visit our facilities through the interface with the National Population Register, as well as linking with the National Health Laboratory Services, where we're working very aggressively to reduce the expenditure on the NHLS by reducing the retests and the cost of doing retests at our primary healthcare facilities. Chairperson, thank you very much. That is the HPRS piece. MEC, I will then, with your permission, hand over to my colleague, Mr. Chris, to do the audit finding.
Good morning, Honourable Chairperson and committee members. Honourable committee members, good morning, MECs and HODs. My name is Chris Elefthero. I'm the Chief Financial Manager for the Department of Free State Health. Once we're done with the presentation, I will then quickly just share the video of myself. With regards to the department, we had two main qualifications from the Auditor-General in the previous financial year. This was linked to the immovable asset register and the work in progress register, as well as the classification of capital expenditure. With regards to the immovable tangible capital assets, the first issue was just regarding a limitation of scope where we had insufficient audit evidence with regards to immovable assets and a prior restatement that we had done. The main reason for this is our historical asset register was based on a project listing, which dates back as far as 2007. In order to rebuild that listing into an asset register, we've then gone back to the full population, and we were able to rebuild all the payment advices, invoices, service level agreements, purchase orders, and completion certificates for the previous 10 years, as far back as 2015-16. We were able then to restate and correctly disclose that amount. For the period prior to that, what we've done there is we've gone to the Public Works Asset Register as the custodian of the immovable property in the province, and we've looked at what their take on values were and their take on dates for certain projects and properties, and we've considered that in relation to our capitalization process that takes place. In doing this, we were able to eliminate certain duplications, as we would not necessarily disclose that construction project if it's already in the Public Works Asset Register. So that assisted to mitigate some of the challenges there. The two key risks around that we were facing with was the first one, that the historical register would have an asset or with a project value that seems to be overstated. So we would have a project, let's say, with the value of 100 million, but when we went to the actual detailed build of that and all the payments that make up that project, we would only get to a value of, let's say, around 80 million. So that led to certain corrections that were needed due to those mathematical errors. Obviously, that error itself is not something that we can support with documentation. However, what we can support is the revised value. So if we said the project was in the value of 80 million, we would have the support for that. So we were able to restate comparing to that. And then the second issue is we had certain projects on the listing that were very generically crypted, where it would be just a project that was saying Tabu Muftsiniana improvement. This is too generic for us to have gone back and identified the specific project and the facility. So what we've done for those is we've also just done that matching exercise to say, when did Public Works take on their values for immovable assets? Most of this was around the 2012 financial year, and anything prior to that, we had comfort that the risk is mitigated in terms of we don't have the detail behind these projects, but at least we know that there is some capitalization that's taken place from an accounting disclosure point of view. The next part was regarding assets that we had included in the immovable asset register but no longer met the criteria or the definition. In the main, this was regarding temporary COVID-19 structures that obviously were erected at the time but subsequently have been removed. So obviously we had to just go through a process of de-recognizing those assets from the register. We've also been able to correct the classification based on the classification guideline that we've developed within the province. This is in the main just to sort out between something that should be capital in nature. So when is it truly improving the value of the property, or when is it more just a repair or maintenance that is required to the property? The third element was around the capital work in progress. So that had the same documentation challenge in the past, as well as the restatement that took place. We've gone back to trace those supporting packs. We've scanned them all in. We've restated the balance with regards to the payment packs that we have. Where we found that certain work in progress projects were completed, we've obviously changed the classification from work in progress projects to capital project as a completed project. And that would mean it would have met the criteria of ready for use or practical completion in essence. And we've also then done the accounting transaction to move it from the work in progress register to the completed project register. With regards to the fourth one, this was differences identified between the actual project expenditure itself and the registers. This is similar to the first item that we referred to, and this is where we went back to the full population of the payment analysis that we have. We use the payment analysis because of the modified cash principles, that we recognize the assets at the actual cost paid. To ensure completeness of that, we've gone back to the actual accounting systems, the financial systems that we use, in particular Logos. We were able to then trace the complete transactions around certain projects just to ensure that the value is correctly reported. And then just the second main qualification that we received was then the classification of the expenditure itself. So where we had included expenditure under capital, which should have been goods and services in essence. What we did there is we developed a classification guideline using the principles of the modified cash standard and SCOA accounting, together with the engineering standards, where we then came up with just a model to say this is how we would classify our projects going forward as well, so that we don't have a repeat in the future. And then we took that same guideline and then we applied it retrospectively to say, okay, where do we need to go back and reclassify projects in totality, as well as looking at the last 2 financial years expenditure in terms of the actual reporting of expenditure. That meant that we had to go back and pass certain accounting correcting journals as well, which we then did pass before we submitted the final financial statements to the Auditor-General on the 31st of May. With regards to the department's trading entity, the medical depot, they also just received a qualification. It was 2 items that were impacted by that. This was regarding the calculation of the inventory based on the weighted average cost calculation. And that same finding would also impact the calculation of goods and services, your cost of sales in essence. What happened there historically was there was some missing data, and due to that missing data, it skewed the calculation, which then led to the error. What we then went and did is we went back to CETA themselves. They assisted us with recovering the missing data from the system. We were able then to rebuild the calculation itself from scratch, and that difference that we identified, we passed through as a prior period error in a correcting journal. We also put the control in place that in the 24-25 financial year, no similar repeat would happen on the system. We also did daily backups of the system just to ensure that if there was any situation where data was missing, we had multiple backups so that we could rely on to get the complete set of data. In essence, that restatement would then resolve both the inventory as well as the general expenditure qualification that we received there. Thank you very much, Honourable Chairperson and committee members. Maybe just to, as per the request of the Chair, just to share the video. I hope I am visible, Chair.
Yes, we see you, and we
Thank you,
saw
Chair.
you the whole time while you were presenting.
Apologies.
Thank you very much.
Apologies, Chair. Thank you.
Thank you, CFO. Thank you, Bandile, as well as the MEC. We really appreciate your presentation. So without wasting any time, we will move over to the Western Cape. If the MEC is already on the platform, Honourable MEC, over to you.
Good morning, Honourable Chair, and to the Honourable members of the Select Committee on Social Services. We're very happy to present to you this morning on the HPRS as well as the audit findings for the 2023-24 financial year. On the line, we have Dr. Sadiq Karim, who's our acting HOD. We have Mr. Simon Kay, who's our DDG for Corporate Services. We have Ms. Andan Corsi, who's the Chief Director for Strategy. Then we have Ms. Lamini, who's our IT Director and who will be driving the first part of the presentation. And then we also have Ms. Shand, who's our Director of Health Intelligence. So we have senior management in the room and we'll be able to respond to any questions that the members may have. Before we get into the presentation itself, I'm going to ask Dr. Karim just to tee us up. Thank you, Chair.
Thank you, Minister and Honorable Chair and members. I hope my camera is visible. Just one or two general comments. Thank you. Just one or two general comments from myself. Western Cape has always had quite a formidable IT and data capability, and we have had for many years. And it's a complex infrastructure that's linked via an architectural system, I guess I could call it, but ultimately allows us not only insight into individual patient data, but also allows us at a systems level to be able to decide on various program implementation aspects, for example, HIV, TB, etc. Second point perhaps just to make is that with all of the data sets that Ms. Dlamini will present, we are able to very neatly develop quite visual demonstration, visual databases and data sets that allow us to demonstrate where the pressure points are. And as a result of that, we are able to obviously develop a health system response that obviously not only includes the public sector, but also includes the private sector. And it's because of this data capability that we've got that when we had the NHLS cyber attack, as well as the EMS cyber attack, our clinicians had sight of individual patient data. So our services were able to continue. I think the third point, perhaps from my side, lastly, is that I think it's quite important that given all the different architecture that Mr. Dlamini will give members, honorable chair members, an insight into, it's important that those systems are interoperable with each other, not only with each other, but also obviously with national systems so that we are able to have bi-directional flow of data. I think that's also quite important. And then just perhaps lastly, Mr. K will deal with the AG findings. But Minister, that's all just from my side, just as an overall high-level response. I think ultimately it's important that we obviously make sure the data systems are able to allow us to have sight of individual patient data so that patients can be tracked, treated, and we can trace individual patients, for example, TB defaulters, etc. But thank you, Minister, and I'll hand back to yourself. Thank you.
Thank you, Dr. Karim. I think let's jump straight in. Ms. Dlamini, if you'll do the driving for us. Thank you.
Thanks, Minister, and good morning, honorable members. If you can just give me a minute to share my presentation. Okay, I hope you can see my presentation.
Yes, it's on the screen. Thank you.
Thank you very much. Good morning once again, honorable members. My name is Nobukhosi Dlamini, and I'm the Director for IT in the Western Cape Department of Health and Wellness. So to start off with our presentation, we wanted to give a bit of background regarding the history of our digital space, as well as with regards to the HPRS implementation. As Dr. Karim has alluded, that the Western Cape does have a long history of implementing systems, and we have quite a mature environment, which I will take the honorable members through. So in terms of integrating with the HPRS system, the project started as early as 2015, when the National Department wanted to pilot a Patient Master Index interface. And the Patient Master Index is basically a registry of patients in the Western Cape. So if you consider the HPRS as the national registry, our Western Cape PMI is the local registry of citizens who are beneficiaries of health services in the Western Cape. And at the time, the Western Cape Patient Master Index was the most mature in terms of development in the health service. So the project was both led by the Department of Health as well as the Western Cape for us to identify the requirements for a patient registry system and what it entails. And that was how the Western Cape PMI and HPRS journey began. So we then had a project to have an integration with the HPRN in order for our patient master index, which already had quite a huge database of patients at the time, to be sent on a daily basis to the HPRS. So that the HPRS can have a record of all the patients that are in the Western Cape environment. And the first phase of that, which was our patient master index sending information to the national system, went live in June 2020. And the second phase of that would have been the bi-directional feed of the HPRS sending data back to close the loop so that we have a complete record of the patients. That phase is still outstanding, and we are awaiting for an agreed specification between the Western Cape government and the HPRS teams to complete that bi-directional interface. So currently, we are sending daily updates from our patient master index, which is our patient registry, up to the HPRS since June 2020, and that feed is currently active. So a visual representation of this is prior to the 2000s, the early 2000s, we had an offline patient admin system, which was like a manual system of registering patients. And in 2001, we went live with our patient registry system, which is called the Clinicom PMI. And it's been rolled out across 53 of the 54 hospitals in the province. And that same patient registry is also shared in the primary healthcare sector. We have a system called the Primary Healthcare Information System across all our primary healthcare facilities, as well as in the city of Cape Town primary healthcare facilities. So all those different sectors share the same patient master index, so that wherever the patient goes within the province, we all use the same patient registry. And as I've mentioned, we have been sending daily feeds of that registry since June 2020. And we're still awaiting permission for the feed to come back from the national system. In terms of users, we've got 7,787 active users, that is both clinical staff and admin staff, who use the patient master index in hospitals. And in the primary healthcare sector, we have just over 9,000 end users at our facilities. And we have a patient count of just under 9 million patients at our primary healthcare facilities in the province. And of those, 2,500,000 or so have visited the facilities in the last 5 years. And that's based on encounters and appointments. So overall, we have just one hospital that has yet to be connected to the patient master index. And that is because we are awaiting the completion of the network connectivity upgrade so that they can be able to have connectivity to access the system. In terms of the patient master index, we have about 16.7 million patients registered on the patient master index. And even though that's slightly above the citizens that we have in the Western Cape, we identify that there are possibilities of duplication of patients. And I'll speak a little bit later on how we're planning to address that. But it's also a reflection of patients who visit our facilities who are not South African citizens, who are migrant workers from outside the province and also outside of the country. So we have a lot of people from outside the country, from other countries, who would then need to use our facilities, who are registered on the platform. And we are looking to implement biometric systems which connect to Home Affairs, which will help us to identify the patient and be able to streamline the patient folders so that we reduce duplications in the system, but also we're able to then identify external patients who come from outside the country, and we're able to report accurately on that. In terms of the NDOH goals with regards to HPRS, which is the system, and the HPRN, which is the unique number, the goals are to have a single beneficiary database for the country, where the details of the patients can be obtained in one single database, and to have a single patient number for each beneficiary in the country. And for all the systems in the provinces to use the National Transversal Master Files, and for systems to use standard clinical terminology, and for our systems to be interoperable with the Home Affairs databases, and for us to have interoperability between HPRS and systems using the HPRS information as well as the HPRN, which is the unique number. The implementation of biometrics to address issues of duplication of beneficiary details, and for the close collaboration with provincial health departments as well as the private sector providers. So all the health services countrywide are required to use the unique number, which is the HPRN, and we support the use of a unique national beneficiary number, which can identify the patient wherever they go in the country. And we also identify that the use of a number does not require use of the HPRS. And one of the challenges we have is that the maturity of our systems environments, which are more than a decade ahead of the implementation of the HPRS, we anticipate that it would cause impact and disruption to our services to implement HPRS in our environment. But we support the use of the HPRN. And that is one of the reasons why we do send an update of all our patients in our patient registry up to the HPRS on a daily basis to ensure that all our patients do have that unique identifier on the national registry. We also support the Health Normative Standards Framework, and we've built quite a lot of work around the Health Normative Standards Framework, which is the framework that allows for interoperability of our core systems. We've benchmarked all our core systems to look at how they perform against this framework and these standards, and all the systems that we build within the Western Cape then incorporate the Health Normative Standards Framework as a core standard in the requirements. We do want to minimize any disruptions to health services, and we note that previously there were allowances discussed to accommodate our patient master index number within the HPRN number systems. We'd like to allow for the Western Cape to use biometrics interface with Home Affairs, which could be a cost-effective solution across all our services that will address issues of duplication of patients so that we really do have a single folder number, but it will also help us to then identify visitors from outside of the country who make use of our services. Just to reflect on some of the impacts we anticipate with replacing our patient master index with the HPRS. It's the cost involved for all our hospitals. As I've mentioned, all the facilities, health facilities within the province, including the municipal facilities, make use of the PMI. It's very embedded and it's widely used. And it would be highly costly for us to do a rip and replace, as it's called, of the current system with a new system. And currently, the Western Cape government doesn't have the additional funds to undertake the work required to replace the Clinicom Patient Master Index with the HPRS system. Also, all our systems within the Western Cape are under an SLA. So that when we implement HPRS, it would sit outside of any current SLA that we have in the province. We note that the HPRS functionality doesn't match the current PMI functionality, and it might mean a regression in the level of service or quality and responsiveness of the Patient Master Index, which might negatively impact patient services. We also have a concern around access to the data. So we always have a full set of the latest available patient information in our source systems, and we have a provincial health data center that we make use of to optimize business intelligence and data analytics functions. And I'll talk a little bit about that in another slide, which is an important reason why we need to have all the latest information from our source systems in the services to reflect in the provincial health data center. We also have a strong requirements with our services that our Patient Master Index must have an uptime of 99.99%, and that's an SLA metric that we monitor with our service providers to ensure that we do maintain that uptime. And any downtime that might be experienced by HPRS will impact all patient-facing systems, which is the hospitals, Clinicom, the primary healthcare information system, Premise, which is the City of Cape Town primary healthcare system, and all other clinical systems that make use of our Patient Master Index. And we would require system support for the PMI to be equivalent to what is already in place to support our services. Our Clinicom PMI is also an intermediary for all other patient administrative systems, as I've mentioned, in the primary healthcare environment, but also for clinical systems. So we have, for example, a system called CARES, which is a referral system that is used by clinicians to refer patients to other facilities. There's an emergency center system called HECTIS, which is used to manage the emergency sector. There's the continuity of care system for clinical notes that is used by doctors. There's the pharmacy systems, lab systems, PACS-RIS, which are imaging and radiology systems, and a lot of other systems that make use of this Patient Master Index as its core. It's our unique source of truth in terms of patient information that all other systems then feed off in the environment. So just to go back on the issue around patient data. So when a patient comes to our facilities to seek healthcare, they're registered on the Patient Master Index and a folder number is created, and any information regarding the treatment of that patient is captured against that record in the Patient Master Index. Then we have our data center, which consumes information from all our systems in the environment and processes that, so that at the end of the day, the clinician has one single view of all patient information that is captured across multiple systems. And that allows the clinician to be able to make well-informed decisions, to have actionable insights, to actually implement patient-centered care, which is a key strategic objective of the Western Cape Department of Health and Wellness, to be able to have that patient-centered care. And this architectural design allows us to implement that. Furthermore, the data is also used for decision-making at a higher level. So we're able to see where the pressures are in the environment. Decision makers can interrogate our data based on all this information that is collated and transformed in the Provincial Health Data Center. So it's quite important for us to have clear visibility of how we would then access patient information back into the province. I did mention that we have quite a complex environment, and this is a visual representation of all the systems that we have in the environment, which support the patient journey across the board. And as I've mentioned, the Patient Master Index, which is our patient registry, is at the center of this. So it's quite a complex architectural view that we maintain and we manage. One way of looking at it is to take you through a journey of a typical journey of a patient. So when we start here, we can say a community health worker can go and visit a patient at home, and they use an application which we call CHAMP, and they can register a patient on CHAMP. And then if they feel that the patient needs to be transferred to a facility, they can then refer them on a platform called CARES, which is a referral tool. And then the ambulance uses a system called EMS to then to pick up and transport the patient to a facility, to an emergency center. At the emergency center, there's a system they use called Hectors. And also at the hospital, there's an electronic content management system which stores our medical records. And we have what we call a single patient viewer, which resides within the provincial data center that I've mentioned, where the clinician can have a single view of all the patient information. We have the NHLS for the labs and the lab results. We have imaging and radiology systems. We have, they might need to go to a theater, so we have a complete utilization of theater system, which is called CAT, which is able to create an appointment for the patient to go to theater and has all the patient information in a digital format. We have nuclear medicines implemented at some facilities. We have cardiology implemented at other large facilities. We have the continuity of care record, which also extends the clinical work and the clinical notes. We have our pharmacy system, and we have the patient-facing interface, which allows the patient to view their own information. And all of these systems that I've mentioned here pull the information from the Patient Master Index as the single source of truth and the patient registry system that we have in the environment. With that being said, we are piloting a system from the National Department of Health called e-Impilo, which is supposed to be used in the primary healthcare sector. We'll be piloting it alongside the other provinces who will be piloting e-Impilo at 2 facilities. And the aim of this pilot is to evaluate the functionality, the user experience, the system support, the operational viability within the Western Cape. And we want to also ascertain the suitability of e-Impilo for primary healthcare services delivery in the Western Cape model. As a part of this pilot, we'll be documenting our journey, identifying any gaps to improve the system, opportunities for us as the Western Cape to use the system, and any risks that are identified by the clinicians. So in terms of our integration with the HPRS, we do note that we have done quite significant technical work. with the National Department of Health, and we'd like to explore technical options for that interoperability between our PMI and the National HPRS, so that we can have a return feed back into our patient master index from the National Department of Health, as we are already sending the one directional feed to the environment. I will then hand over to our CFO, Mr. K.
Thank you, Nobukosi, and good morning to the chair and the members and the Honourable MEC and HODs and colleagues. I'm going to take us through a couple of slides on the Auditor-General findings for 23-24. These are extracted out of both the audit report as well as the management report. So the overall audit outcome is unqualified with no findings. In other words, it's a clean audit, and that has been maintained from the previous year. And in fact, 23-24 was the sixth clean audit that the department has achieved. There have been no material irregularities identified at the department. On the performance planning and management, the performance management and planning processes and the strategic plan and the APP, there were no requirements, there were no findings that were identified in that component of the audit. Next slide, please, Nobukosi. Thank you. On the audit of annual performance, the AG did not identify any findings on the completeness of indicators used for planning and reporting on performance, nor did they identify any findings on the overall presentation of performance information in the annual performance report, nor did they identify any misstatements in the reporting of performance information in the annual performance report. And therefore, the AG did not identify any material findings to report in the auditor's report. And the last slide is the conclusion of the Auditor-General, and I quote, "The department is commended for maintaining their clean audit outcome for a sixth consecutive year. Creating good governance and administration to achieve a clean audit outcome requires a combined effort from all role players in the accountability ecosystem, and maintaining that clean audit outcome requires continuous focus on financial management, performance management, and compliance, while also ensuring that service delivery is placed at the forefront. The department has maintained this position, notwithstanding the challenges of the budget constraints and the increased demand for healthcare services in the province." End quote. Thank you very much, Chair and members. That's the end of the presentation. Thank you. Thank you, Minister.
Thank you very much to both our presenters. Chair, we hand back to you.
Thank you very much, Honourable Minister of the Western Cape, for the presentation from you and your team. We really appreciate your presentation. Honourable members, it's now over to you. Any questions of clarity? Honourable Sibande, Honourable Duplessis, Honourable Faye.
I can't raise my hand.
Fine then, Honourable Aris, Honourable Breed.
Honourable Mukweli.
And then Honourable Mukwele. Honourable Sibande, over to you.
Thank you very much, Chairperson. I wanted maybe to welcome all the presentations from the three provinces, but nevertheless, we will go for clarity seekings for some reasons. Number one, I'll start with the Eastern Cape. You see, Chairperson, I was a little bit touched when they present this presentation that they have got 764 out of 777, meaning approximately 98% is covered. I'm not sure but I'm subject for correction by them from their input. Let me give the historical background. The Western Cape is one of the provinces which is overpopulated, and in some stage, from my little understanding, there were some challenges. I'll put an example, but they will correct me. With this new system which we have requested, we have areas like esidwadweni, omvezo, bocunu, bobambane, bokhoza, bomtandule. I don't know whether they are covered or not. Because sometimes when we give these reports, we can focus on the hospitals which are there. What about the clinics, whereby some of the people are consulting? And then also, they've raised the issue of challenges themselves, that they've got poor connectivity in rural areas, and also the withdrawal of technical support, and no main, and then the issue of no maintenance follow up is them put them like that. And then which is worrying me, which they must also update us that how to tackle this one. They've said they put aside the money which is equivalent to 29 million rand. So my question is, the province going to utilize that money, this money, before the financial year end? Because what I'm scared, Chairperson, sometimes the department is pumping a lot of money, and only to find that in terms of the implementation of their responsibilities which they are given upon to them, they are facing challenges. And then I would pass there. And they've reported that they've got 2 officials, managers from the internal financial control directorate. I was going to ask about that structure, where is that structure functional or not? Because you can have managers to come and solve some problem while the structure itself is not functional. They must clarify us on that one. And then the issue of audit funding. They've indicated that audit funding is still underway. And they've said there are no major issues. But under that also, they've indicated that they've got challenges of materially irregularities, and also non-submissions and shortage of staff at legal whatever. So that is the short in terms of Eastern Cape. And then come to Free State. In Free State, I don't know. Also, I will ask. They've said they've got 253 operating to HPRS. That means 100% coverage. And they've raised the issue of the key success, of which is correct. Now, as this presenter goes on, they've raised the issue of two, I don't know whether 2 clinics or 2 hospitals, like they indicated when it's basically Kabi, whereby the facility is not functional. I don't know the other one. I've forgotten to catch the other one. I need the clarity. For how long is it going to be attended? Because it's them who reported that these 2, they are not functional. And then, which is worrying me also, the issue of Tabam Futsanyana, whereby they've said they are servicing people from Lesotho. I will be very much grateful if they can give us maybe statistics that the people who have been services then, this is the number of people, and then the people from outside are this number, because it's them who raised the issue of the people from Lesotho. And then also the issue of auditor findings. They've said, I'll touch the issue of risk. You see, it's worrying me in terms of financial implication. They've raised the issue of historically that projects value cannot support, they've said the project value cannot support what they've got at the moment. And then to me, there are such discrepancies in that one in terms of the Auditor-General, which is ongoing. And then the project in Kaptet, in Taba Mafusanyana, they also must take us on board that exactly what is it. And changing of classification, compliance with financial requirements. Also, that's what they've raised. And then go to Western Cape. I won't belong, but I will take some few in Western Cape. Western Cape, when the MEC open, they said they've got a formidable systems with cyber also system, which was and long history of implementation system. But as it goes on, I think so far, you are only only province who raised the issue of migration workers. I don't know, maybe it refers to members that we've migrated as well. And then we said you are covering 16.74 million. But you said also you got one hospital to be connected. You didn't indicate the name of that hospital. And then my question is then, by when is that hospital going to be covered, be connected? And okay, let me leave there to give it the opportunity to my colleagues to come in. Thank you, Chairperson.
Thank you, Honorable Sibande. Honorable Du Plessis.
Thank you, Chair. And this is, I'm not sure if you can see me, just to be sure that this is me. And I'm also wearing an orange scarf for GBVF awareness. Thank you very much to all the departments for presenting on the HPRS as well as the Auditor-General findings. There's one question in general, and I'm not sure, Chair, I think we might have to ask the Minister this, but how far are we as a country from having a cross-province connectivity and a data system that can give the medical history of various patients regardless of where they are traveling within the province? So I'm not sure if anybody can answer that, but if somebody can, that would be fantastic. With specifically to the Eastern Cape, it's wonderful to see that you are putting in solutions where there are ITC connectivity issues. The question that I do have for you is, how long have you been implementing the HPRS system? And then with regards to the AG report, it seems that you've covered the basics, and also that it's more of a comment that you are improving on the ground with regards to medical healthcare in the Eastern Cape. So not a lot of in-depth, but a lot can still be done with regards to general infrastructure as well as general healthcare support. Within the Free State, your connectivity infrastructure, I wasn't entirely clear when the planning started to ensure that the HPRS has the infrastructure, the ICT infrastructure within the province. So when did the planning start and how far are you? Within the Western Cape, what has been the impact in minimizing the burden of disease for your data management systems that you have in place already? How are you managing e-health and data within smaller clinics, provincial smaller clinics, as well as district clinics and hospitals, to ensure that there is enough ICT infrastructure for smaller clinics? And then how are you managing your medico-legal issues within the province? Thank you very much.
Thank you, Honorable Du Plessis. Honorable Fanny.
No, thanks, Chair. Let me just also show my face, but for the purposes of convenience, I will shut it off. Yes. No. Let me first welcome the presentations from the different provinces that made their presentation. I think it's a work, a good work in progress. I must mention that I just want to check, Chair, specifically Eastern Cape and Free State are more rural as compared to the Western Cape. Understanding the dynamics indeed of what informs that. How is the integration specifically as highlighted, on the reports currently, to your new system that have been introduced, and is it working or assisting specifically with regard to the reference that I've made of rurality of it. I know I do not want to comment. Also, last time I was in Port Elizabeth, I'm using public hospitals. It was easier for me to live with my file in my hand. Took my file and I left with it in one of the hospitals there. I came back at a later stage and there was no notice that I've left with my file, and then I came back. I just want to check also because it is not a rural area, but it is a township that I was at. Very, very poor townships. How is this process, especially on the clinics in our townships? Whether you talk about Free State, whether you talk Eastern Cape, and also, you see, in Western Cape, I hope, as I've seen, I hope in terms of the H's report that is giving a green, a green light in terms of their performance. I hope the information is also related, because we are having some challenges, specifically to the areas that poor people are residing. Even if you can go there now, you will find out people are sleeping on the floors, because in terms of the long queues that, they are waiting for. So I just want to check, with that generic question. The second one is around the question of medical legal claims. I know it's one of the challenges that most of the money that the institutions money that is being budgeted for is mainly going towards that. And even today, what mechanisms are there in order to ensure that this is being minimized, understanding that sometimes is unforeseen circumstances. Those can be argued, but if we can look in terms of the reality, that is where most of the money of the public health, the department is low, and lawyers are making a lot of money on this field. So just want to check, as compared to previously, are we making any differences in terms of minimizing? I see the report, but can we safely, confidently argue that we are moving towards the right direction, and these measures that we are currently utilizing are the ones that are assisting us. Because I will tell you why I'm arguing as such. Thank you, Chair. I think I will stop there now.
Thank you, Honorable Fanny. Honorable Aris.
Chairperson, thank you very much. Good morning and thanks to the presenters. Chairperson, I just have a few in terms of the Eastern Cape. I just want to check with them what measures they have in place, to ensure that this filing system is being rolled out to all, specifically in the Eastern Cape. You get very rural, clinics and etc. And because we have done some oversight visits and we have found that many of these clinics are still on the paper trail. And then also in terms of the auditors, the AG's findings, I want to find out from them what measures does they put in place to deal with the medical negligence that they currently are facing, because that impact the budget ultimately, in terms of service delivery. Money that is meant for service delivery must go into medical negligence. And then also, Chairperson, in terms of their fleet, I want to check how many of their fleet is still grounded and is not fully functional. And then also, we have seen recently many of times in the news that, the shortage of medical equipment. I want to check with them. They must bring us a report on how they deal with this shortage of medical equipment, and then also the filling of vacancies, because we have seen that even CEO positions is not filled, and because of that filling of key vacancies, that ultimately result in instability in this Eastern Cape hospitals. And I want to check with them what measures do they have in place to ensure that there's stability in our facilities in the Eastern Cape. And then in the Free State, there's a pattern of non-compliance with legislation that impact procurement processes. And I want to check with them what measures did they put in place to prevent possible fraud risks. Because once there's fraud, it is money that is meant for service delivery that is going into people's pockets. And then also in terms of the consequence management and the staff that fail their responsibilities, the department must provide us a report on all those consequence management, those disciplinaries and those criminal charges that they have laid. So we need a report on that. And I want to check with them what plans they have in place to maintain and refurbish, the infrastructure. And then also, Chairperson, in terms of the Western Cape, recently, I have done oversight visit in the clinic in Pakkelsdorp. Chairperson, I have bring it to the attention of this portfolio many of times, and I again raised this issue today. This clinic in the Western Cape, I think it's for a couple of years. I think it comes from 2014, 2015. That clinic was supposed to be, upgraded. And I can assure you, Chairperson, there was money available for that upgrade of that clinic. That clinic is in a poor state. Let me tell you something, Chairperson. The files is all over as you enter that clinic. The files, there's not even place for that filing system within that clinic. Right now, there was money availed. I don't know how many million was availed for the upgrade of that clinic. The only upgrade that they have done there at that clinic in the Western Cape, in George, in Pakkelsdorp, is 2 containers that they put there. Nothing have happened. The state of that clinic is poor. Even when you enter the door, it is faulty. And that's a health facility, and that itself is a health risk. So, Chairperson, we seriously need to look into that. And then also in terms of the Western Cape, I want to check with them in terms of the delays in filling vacancy posts. What is their plans? Because there's a lot of vacancies within the Western Cape that is not been filtered. That is a serious challenge for our people and in terms of service delivery. Thank you, Chairperson.
Thank you, Honorable Aris. Honorable Breed.
Thank you, Chairperson. Just a proof of life, but my signal is very bad, so I'm going to switch off my camera if that's fine. Chairperson, I'm going to focus on the Free State as I am from the Free State. A lot has been made mention of, a lot of questions has been raised, but let me raise a few more. I think there was mentioned of the network and the connectivity issues and the infrastructure. How are we going to combat that? I think Honorable Feni also mentioned and said, he comes from a rural province. The Free State is quite rural, specifically if you look at Thabo Mofokeng, if you look at Kwakwa and all those mountains and how bad that connectivity is. I want to know what are our strategic plans to try and address and improve that, to ensure that all of our healthcare facilities can actually be connected to the network and use the system. Furthermore, what are we going to do to improve the booking system that is being used? We see in the Free State, it is a finding that it has not been used, and we are and we're seeing long queues. I mean, it's the same story in most provinces, but that is really hampering service delivery, Chairperson. Then staying with PCs and IT infrastructure, but diverting a bit from that, how are we ensuring that our healthcare facilities are actually up to standard to be able to handle this new system? Yes, in terms of connectivity, but in terms of other things. For example, and I want to use the Hill Street Clinic in Kroonstad in Mukaka in the Free State. I was there on an oversight visit at the end of April, and they actually were very gracious to walk me through there. And there is a roof leak right above their computer and right at the information desk where their computers are on, where they deal with the folders. So they say they kind of move it around, try and put the emmertjie here and the emmertjie there to try and work with it. But the fact of the matter is their files are getting wet, their computers are getting wet, they are burning out, and that's just because the roof has got holes in it and because the MOU with the municipality for the renting of Hill Street isn't being complied with. And that's not even getting to the other basic facilities of specifically, for example, the Hill Street Clinic. So I really want to know what is the long-term strategy in ensuring that the rest of the infrastructure is up to standard and ensuring that we do not lose our computers. Chairperson, then we have a lot of hard copies of patient files. I know, and this was a few years back, I was at one of the provincial hospitals in the Free State, where there was this big room with patient files in, and I asked, how is it categorized? And they said, well, there used to be a system alphabetically, but then it got deurmekaar, so now they just put files in. And I said, well, how do you find a file again? They're like, no, we just usually open a second one, or a third one, or it's quite possible that somebody has multiple files there. And that is a matter of concern, Chairperson, because when are we going to digitize those folders, and how are we going to access them, and how is that going to work, and what is the plan for that, and what is the deadline for that? Because taking two municipalities who were supposed to in 2018 be IMSCOA compliant, and in 2025 we are still not IMSCOA compliant, I really do not have hope for the Department of Health when you look at digitizing and doing all of those things. Also, then my last two questions, Madam Chair, is what is it going to cost to get all of our hospitals and clinics and all of our healthcare facilities online and onto this platform? And then lastly, Chair, is will the system be able to, I think it was the Honourable Aris that made mention of the procurement system and the problems we are experiencing with procurement at the end of the financial year in in March and April, our clinics, our hospitals always seem to run out of medication in the Free State. I know in some other provinces as well, but specifically in the Free State, where they don't have chronic medication. Will the system ensure that we can plan ahead, that we can actually see our usage and make sure that we can plan accordingly, buy medication, so that we don't get to the last quarter of the year where people that are reliant on these medications can't actually get them because we don't have money and we don't have stock. I will leave it at that. Thanks, Chair.
Thank you, Honorable Breed. Honorable Makwele. Honorable Adrianse, you can proceed.
Chair.
Okay, sorry, Honorable Adrianse. Honorable Makwele, over to you.
No. Thanks very much, Chair. I wanted to show my face so that you can see that it's me. But let me switch off so that I mustn't have a problem with network. Chair, first and foremost, let me thank you for affording me the opportunity, and also take this opportunity to greet honorable members, my colleagues, members of the Select Committee, our MECs from the department that presented before us, the officials, and all of us in the visual platform, and all protocol observed. Chair, first and foremost, let me welcome the presentation from the three provinces that presented before us at the Select Committee, and also take this opportunity to welcome all of them, to say that as the Select Committee, we really appreciate the stride that they made across. But Chair, maybe let me just start by welcoming the presentation from the two provinces. I know the Eastern Cape and the Free State, where I also want to appreciate them, because especially in their presentation, when they were showing eager in this thing of the or on the issue of the National Health Insurance Fund, because remember, I mean, National Health Insurance Scheme. Remember, the NHI is the only ideal that can assist that all South African across they get access to equal health care, which I really appreciate that. In particular, the two provinces, yes, I didn't hear much about the Western Cape, maybe unless it was just, maybe unless I missed something, because the NHI is the only way that will make sure that our people on equal, whether they have or they have not, they will have that opportunity for health services. So that's what I wanted to, that's the input that I wanted to make. But other than that, Chair, with regard to the issue of digitalization of the information across the province, I know Western Cape indicated that they are doing well. They also indicated that out of 54 hospitals, 53, they are fine. But the only question to them, because remember, luckily as the Select Committee, we made an oversight in this province, which I can say that where we went, we find that indeed they are well ahead. But we want to check that. What about at the clinic, where at the most rural remote areas? Because you know that is where matters most. I'm not saying that at the urban area doesn't matter when they are able to, I mean, to make sure that they are able to trace each and every information for every patient that will come in their hospital across, irrespective where that where that patient report. But I just wanted to check with regard to the issue of with regard to the issue of at the remote area, deep rural area within their province, which I believe that other provinces, yes, I will agree that other provinces need to come to Western Cape to cope, which we really appreciate. But we must make sure that whatever good things that they do in the Western Cape, especially at the urban areas, it must also cover of the poorest, those that they can't even afford medical aid, those that they can't do anything. So I should think that is what I want to check. What plan do they have so that they can even go to that? Lastly, Chair, on the issue of the connectivity, they across the province, they've also indicated the challenge of connectivity. I just want to check with them that what action are they taking, especially in collaboration with the Department of Communication? Because, if let's say they are coming up with the system that has got some hiccup with connectivity, that is where they've got the. I understand that as Department of Health, it must. They can't have that capacity to make sure that they deal with the issue of connectivity. But I just want to check about their issue. What stride are they doing in making sure that they collaborate with the department that deals with that, the Department of Communication, and then also that one department that deals with technology. So, Chair, those are the few questions that I want to ask to the province. But other than that, we really appreciate what they presented before us. I thank you, Chair.
Thank you very much, Honorable Mokwele. Honorable Adrianse, over to you.
Thank you, Honourable Chairperson. First, let me acknowledge the work that went into the presentations. I want to thank you for that. Actually, you answered a couple of my questions which I had beforehand during these presentations, and the rest, a lot of them were covered by my colleagues that went before me. To the Eastern Cape, I am just quickly going to switch off my bandwidth to ensure that, my video to ensure that everyone's bandwidth is covered. Okay. To my colleagues, to the Eastern Cape, I would like to ask, you have spent on e-health, you indicated 159 million, yet we still struggle with a lot of issues. Now, you said you have a technical team now ready to assist with technical challenges. Now, usually when they're centralized, it takes time to get to the technical glitch where it is, when they can't fix it online. What is the time frame it takes for them to reach the different parts? What do you allocate for time to fix these technical glitches which they can't fix online? Do you give them a week, a day, a month to come and fix it? Because this can be have a severe effect on the rolling out the HPRS system. And yet again, every time there's a power failure or interruption or load shedding, technical equipment is very sensitive to this. How do you experience the setbacks from this and the power surges after this? Do you have built-in UPS systems to protect your systems so that the system doesn't go haywire and all your patient files get lost? And do you have backup systems in the cloud or etc.? And do you have ways of safeguarding? And this is to all three provinces. Do you have ways of safeguarding these patient files? Because it's sensitive information, and we have a lot of hackers who can use it against these patients. So these are my questions to Eastern Cape and some of the other provinces, as I indicated as well. To the Free State, I want to thank you for specifically acknowledging the importance of the HPRS system. And I can't agree with you more because, as we heard from Honourable Breed, in some of the places we have visited, they just open a new file and yet another new file and yet another new file. So planning becomes non-existent as far as medication is concerned, and that makes it possible for a patient to collect and abuse the system to get more and more medication that simply isn't allocated to them and might lead to addiction. So what's the time frame to eradicate the paper-based filing systems and make it all available online? So this is, as you yourself indicated, the importance of this. What timeline are you willing to commit to make sure that all the files, all the hard copy files are digitized? And the same question, I know you are in the forefront, as you stated yourself, but the Western Cape, everything online, what time frame? And then to all three provinces, what happens when the power is down and the internet is down? What backup plan do you have? What do you use? Do you have a downloaded system for the digitized files, or are you completely blank on the patient history? Thank you. That's it from me, Chairperson. I tried not to double up on questions of my colleagues.
Thank you very much, Honorable Adrianse, for not doubling up. To the different departments from my side, let me just get my questions. In terms of the Free State, I understand that the patients that you have captured is more than the population of the province. I just want to check with you guys, are you aware of any duplicates in terms of that system of patients? Because you have indicated that you have an issue with people that is or community members or patients that is not part of the province or that is not from the Free State. And then on slide 2, you indicated that there is on-site support from district facility network controllers. I just want to check with you, is this IT technicians from the provincial department, or are they from the national department? And in terms of their capacity, did they get training from national or from provincial in terms of maintaining or sorting out errors in terms of the HPRS? And then in terms of the Noordnagel clinic that were closed in 2024, I just want to get the reasons from you. And is there an alternative facility in terms of the patients that used that facility in the past? That is all from my side. So now we will move over to the Honorable MEC and team of the Eastern Cape to respond to the questions. Thank you very much, Honorable MEC. Over to you.
Thank you very much, Chair. I will try and respond to some questions, and then I'll hand over to the HOD and the person responsible for IT in the department. Firstly, I would deal with the question from Honorable Sibande that talks about the 777 facilities. Those 777 are only clinics. So when we talk about 764 out of the 777, it's talking to the clinics of the entire province. So it includes this Eswatini and Uno. It covers all. So that's basically that. It doesn't include the hospital. The hospitals, we're dealing them with another system, which is HMS2, of which the HOD will dwell much on it. In terms of the challenges of poor connectivity, it is indeed true that in areas like the OR Tambo, which is not necessarily the connectivity per se, but even the fact that there is no infrastructure in terms of brand. So the Office of the Premier had to first make sure that there is an infrastructure that relates to the connectivity. So the Office of the Premier is assisting us with that. That is why now, as the department, as you said earlier, that we've set aside 29 million. The 29 million now is meant to move from to take a connectivity from the broadband that has been provided by the Office of the Premier directly to the facility and directly to the ward. And we've already appointed a service provider to do that. So we are confident that in this financial year, we will definitely spend the 29 million because we've already appointed in relation to that, the 29 million that we're talking about. In terms of the issue that relates to the staff, the non-availability of staff in the Office of Legal, what we are saying there is, as a department, we have not planned previously because there was no issue of legal claims. But when we realized that there is an influx in terms of litigations and legal claims, the department is now assisted together by the Office of the Premier and Treasury, has established a legal team that has a legal strategy to deal with issues of litigations. But now what we are saying, as the department, we've established a office that is called that deals with issues of prior requests and other things. That is where we are saying, for now, we don't have people that are permanently employed because we're still dealing with the issue of organizational structure in the department. We had contracted people that were focusing on making sure that we make a follow-up on issues that relates to information that is requested by our potential people that are claiming that is the prior request. So we had that team, but the contract has come to an end. And because of the pressure in terms of budget, especially for COE, we were unable to contract all of them, but we've devised other means. We've taken interns that have got a legal background to be part of that and extended, especially those who are dealing with the issue that relates to audit, because it was an audit period. So it was going to be a frustration that we had terminated contract of the people that are dealing with the audit, knowing that this is an audit period. So we have extended that contract for those particular individuals. So we can confidently say that the office is beefed up with interns as well as those that are conducted. In terms of the two managers that Honorable Ms. Bender is talking about, the two managers are assigned to the legal department of the department in order to see to it that all the audit issues that needs to be followed by that particular department that is illegal, the managers are there from the finance part to assist so that we are able to respond promptly in relation to that, to the requests that are required by the Auditor-General. In terms of I think I've dealt with the issue of shortage of staff in the legal services, and the issue that we've issued notices to those who are not responding is to make sure that everyone take cognizance and the importance of the audit in the department. That is why we have managed to respond in all those that we are supposed to respond to. I think we've got only 2 that are outstanding. And yesterday we had a management meeting of which we instructed those that they must respond by the end of today. And if not, consequence management must kick in. So those are the measures that we put in place. And when it talks to Honorable Feni, it is an unfortunate situation that relates to you taking a file home. I think the HOD will have to come into that. But what is important is we are trying as a department to integrate the system, as you said earlier, and being assisted by the Office of the Premier, fully understanding that we are a rural province. Hence, I think I've responded to that. In terms of medical claims, what are the mechanisms that are in place to make sure that we minimize? We are assisted by the Office of the Premier and Treasury. We have an integrated strategy, and we believe that the integrated strategy is assisting us. As a result, we've seen a decline in terms of litigations that relates to the medical legals. But it's something that needs all of us. It doesn't. It needs the Department of Health, because in some instances it has a direct impact with other sector departments like Department of Transport and other sector departments. So that is why it is now an integrated strategy, so that it involves everyone together with Department of Human Settlement and all of those, that we think we can be able to integrate and develop the strategy to assist us. So we are confident that the strategy that we have now is really assisting. Hence, we even went to court, up to the Supreme Court of Appeal, to come up with a strategy that says we plead not to pay a lump sum, but rather provide a healthcare to those that we've wronged as a department. So that is one of the strategies that we are dealing with. I would think I will leave others to the HOD to conclude. Thank you very much. Over to you, HOD and your team.
Thank you, Honourable MEC, through you, Honourable Chair, and thank you for the comments and the questions from the Honourable members, in particular the acknowledgement by Honourable du Plessis of the progress that we are making. Just to respond to the balance of the questions, I'll deal with those related to HPRS. There were concerns raised by Honourable Sibande, Honourable du Plessis, and Honourable Nokweli in particular around the rurality of our province and how do we deal with making sure facilities are able to be connected to the internet and be able to utilize the system. And Honourable members, especially in the most remote parts of our province, it is a challenge. Even for the very service providers who don't have network coverage signal in the deepest, most rural parts, remote parts of our province. And perhaps what we are needing to look at now are alternatives, engagements with the service providers to improve their coverage in where there are gaps. But also we would need to explore Starlink, which we believe is a new provider, to see if their coverage using satellite technology may not be an alternative that can reach these most remote parts. So we're open to working with the providers to improve coverage in our deepest, most remote parts of the province. That being said, in our province, we piggybacked on the Western Cape's broadband initiative. And so as part of that tender, our broadband rolls out to those areas where this provider, Liquid Telecoms, has as the backbone, the infrastructure for broadband. So in areas where they have not yet rolled out their broadband infrastructure, it's in those areas where we now have to use alternate means for connectivity. And that alternate means are the LTE routers or data bundles for people to be able to use the data and then connect into the system, which is not ideal, but we are really trying to find ways to promote connectivity. Honourable members, the other thing that we identified, as we said, one of the members spoke to the challenges that we raised on the staffing. The PEPFAR fund, as honourable members are aware, that directive came out on the 27th of January, and by September we are anticipating a very real possibility that they will withdraw funding completely. And in the Eastern Cape, we've got about 435 million rand, which has been allocated by the PEPFAR funding. About 97% of that is spent at facilities. And that funding has been provided to us providing hands. We've utilized the extra hands that we've gotten in our HAST program to also do data capturing of our systems. So this honourable members are aware that that directive came out without the country and the province having an opportunity to develop a transitional plan so that we can sustain our services and close the gaps where this funding has been withdrawn. To that end, we approached donors, and the Bill and Melinda Gates Foundation has given us additional technical resources to help us do a rapid assessment and then develop a transition plan so that we can have sustainable services even in anticipation of the PEPFAR fund being withdrawn. So that is work in progress to try and address that. And as we said, and I'm going to link this to the business continuity question, I think it was of Honourable Adriansa. Honourable members, you're correct. When there, I think more than one honourable member mentioned that if you have a power outage and the facility goes down, at our clinics where we have generators, those generators may not be able to cover the entire area of the clinic. So we do have downtime with HPRS when we have power failures. And that is why it is so important to monitor the sync. So those sync stats that we presented, honourable members, tells us which clinics, when the electricity is restored, comes back online in order for us to then be able to ensure connectivity, once there's connectivity, to then capture and upload. And so there does tend to be a backlog, and the duplications we referred to comes from when there is downtime, and we now have to manually allocate numbers and then capture it afterwards. With respect to the questions around the record management, as our Honourable MEC said, that incident should not have happened, sir, and we would appreciate if that particular site is communicated to us so we can take steps to try and address it and prevent a recurrence of such an incident. Honourable members, we have at our hospitals the HMS2 system, where in phase 1, it is the master patient index and managing the admission of the patient. As we said, 40 of our hospitals are in the phase, have completed phase 1. So that means if you come into any of the hospitals at any of those 40 clinics, because it's on the cloud, any of our clinicians that has access can access your patient record. The phase 2, we're starting with our central and regional and tertiary hospitals. This is where the doctor actually captures the the patient's health information during a clinic visit on the system. And so we are moving in this direction of an electronic patient record system, decreasing the dependency on paper. And the honourable members may have seen in one of the slides that we also have we're setting up digitization centres. So if at Freya Hospital, which is the most mature site for HMS2, we could, in fact, there are certain units where we could take away that hard copy file right now and they'll be able to manage fully without a hard copy. So that is the vision, is to move in that direction as the institution matures, is to be able to remove the dependency on the hard copy file. At the same time, we've set up 10 digitization sites, one in each of the district. Here we're taking the hard copy records and we're scanning them so that as we migrate to an electronic system, we have a backup of that hard copy system. So this is all work in progress. Honourable members, if I could then move on, if I've covered the questions related to HPRS. If I can move on to the question of the audit, as our Honourable MEC explained comprehensively the arrangement with our internal audit team. For completeness of that question, the internal audit in terms of our organogram reports to the Office of the HOD. So it's independent, and we undergo the Chartered of Internal Audit Standards assessments, and we have achieved the highest grade there. So we do take pride in the competence that resides within that unit. Honourable members, with respect to the material irregularities that was raised, in the main, as I said, they were related to cost of employees. So they're related to 4 particular areas. It's where we utilize the incorrect code 0635, which is only supposed to be for the community healthcare workers. It's the after employees have terminated, that they continue to be paid for a month or 2 because we didn't terminate them immediately. Number 3, it was with our registrars, who were medical officers, and they were incorrectly paid progression at the time. And then the 4th one was nodal allowances and rural allowances, especially where staff moved, and in particular our nurses at the college.
With the last one, our lecturers at the colleges are professional nurses, and so our interpretation was that they qualify for the allowance where they are in sites that have been recognized as rural or nodal areas. So, honorable members, to address the MIs, we developed standard operating procedures and trained our practitioners on that to deal with all 4 of those areas. Every month, our personnel controller draws reports, and we have weekly meetings where our GM for HR engages with the teams where we pick up any errors that were made. Fingers crossed, honorable members, in the last month of May, we just had 1 error that we picked up. So we are excited to see that we're moving in this direction now, with the training and the learning seems to be bearing fruits. Honorable members, with the other MI was on the Microsoft license, and that was corrected in the 24-25 year. In the 23-24 year, it was in particular that our call center had gone on to procure licenses that had not followed the due process, and therefore that is now being dealt with. Honorable members, if I could then go on to the next area, which related to fraud. We've made a lot of effort to try and strengthen controls in our department. And a proxy indicator for any potential fraud is irregular expenditure. Our department in 2020-2021 had an irregular expenditure, in-year irregular expenditure of around 197 million rand. We decreased that to 104 the year after, and since then we've kept it under 6.8, and in the last it was just over 5 million rand in-year irregular expenditure. This is as a result of our team working really hard, our GMSCM working really hard with people on the ground around the standard operating procedures, the monitoring of what is happening, so that, and moving in the direction of electronic supply chain, so that we can monitor procurement, we can identify when tenders are coming to an end, so that we take action in good time to put replacement tenders, renewed tenders in place. So a lot of work has gone into irregular expenditure. The non-submission that was referred to was in fact around consequence management. That RFI, there were 5 employees that had been drawn, and they were identified to have previously been it was a possible conflict of interest. Now, by yesterday, I can confirm with, as our MEC has said, they were given until today, but actually yesterday, that information was provided by our team to the Auditor-General, and we have in fact provided proof of the fact that there was no conflict of interest and that investigations are being made. Honourable members, we have a consequence management committee, as I said, chaired by our internal audit person, who then makes recommendations from that committee to myself for us to ensure that we resolve investigation of any irregular expenditure, fruitless and wasteful expenditure. Where it is investigated, it's handed over to employee relations, honourable members. We had 110 cases at the start of 24-25 in our register. We've put a lot of effort into making sure that we close those off, and we are now down to only 11 cases that are pending, and those 11 cases we are targeting to be completed by the 31st of July. So we are, as our MEC has said, making a lot of effort in holding our managers accountable for these various outcomes. Our in-year regular expenditure has been reported in our annual financial statements at around 5.8 million rand, so significantly reduced compared to where we were a few years ago, and in relation to our overall budget of 31 billion rand. Honourable members, if I can then go to the last 2 areas. The one was on Nelson Mandela Bay and the service delivery issues there. Honourable members, our biggest challenge in Nelson Mandela Bay, being one of the 2 metropoles in our province, it has experienced an increase in the number of people who have moved there. So there is a malalignment between the demand, the increased demand on the one hand, especially for young, we've got 63% of the people in our province are under the age of 30. So there's a huge demand for maternal, women and child health services, as well as an increase in trauma. So there's a huge demand on the one hand, and at the same time, our service requires a significant investment into infrastructure as well as human resources to address the service platform in the western region of our province. We do have a project plan with a detail of what needs to be done and how it needs to be done to address the service delivery platform in the western region, and we can share that with honourable members. But in summary, it's in decongesting our secondary and our tertiary hospital by creating capacity in our district hospitals. And so that is a program that is in place, but it may take long, and I do not want to extend the time of honorable members, but we can provide that plan for you. The last one, honorable members, relates to the medical legal intervention. As our honorable MEC has said, we are implementing an integrated strategy. The strategy was the first objective was to stop the bleeding. So we were successful in that landmark Griffiths judgment, because a lot of the medical legal settlements, the lump sum pain and the accumulation of debt was related to the fact that we had to make these lump sum payments. So that Noyela judgment, where we awaiting the Supreme Court of Appeal, we have been allowed to implement the judgment, and that has significantly decreased the payments that we've made in a given year. Before we accelerated the integrated strategy, we had paid out over 900 million rand in 1 year, and in the following years, we've managed to keep it down under 340 million. So, honourable members, on the medical legal strategy, there's a coordinated legal strategy. Our MEC has already spoken to the different units of the SLU, as well as Norton Rose Fulbright, assisting us on the legal strategy. The third objective was to manage the patient records so that we are able to account for our performance, and that is why the HMS2 electronic patient record system is so important to our strategy. We targeted within those 40, the 28 highly litigated sites. So that is a lot of work with our electronic PAIA system to be able to track these claims or requests for information. And then the final objective under our integrated medical legal strategy is to improve the quality. So we've identified that not only maternal cases, but there are claims for delays in surgery. So we're building capacity at district hospitals in a systematic, structured way within funding to try and improve our capacity at district hospitals to do these kinds of bellwether procedures. But honourable members, you may also be aware that our provincial treasury has headed up forensic investigations into medical legal sites where we have suspected fraud. And we've also handed over 73 claims from 25 firms to the Legal Practice Council. So we're saying in the Eastern Cape, this is not a place where you want to take advantage of us or pursue fraudulent claims against state. We have an active strategy to address those. As a result of the strategy, since the peak of 566 new claims in 2017-18, in the last 2 years, we've kept it at just over 200. So that's a more than 60% reduction in new claims against state, and we want to keep this momentum. But as MEC said, our focus is improving quality of care within the available funding. Thank you so much, Honourable Chair. I hope I've answered all the questions that was remaining. Thank you.
Thank you very much to the department, to the team from the Department of the Eastern Cape. We will move now over to the Free State. Honorable MEC, over to you.
Honorable Chair, apologies, I was struggling a little bit with the gadget this side. Thank you very much, and we really appreciate the insights that have been provided by the honorable members in this platform. I would just like to request that some of the issues that have been raised, Honorable Chair, we didn't come prepared to respond to them, and we'll request that the issues that has to deal with infrastructure, we can submit them in writing at a later stage. Honorable Chair will give us the appropriate, time frame for us to respond in relation to that. Let me just deal with just a few things, and then the two presenters will deal with the questions that have been directed to us. Firstly, on the issue of the litigation strategy, we have a fully fledged medical legal office team that is located within our legal department, within the department, and it is constituted by professionals who come from various backgrounds, and we believe that we have a team that can handle quite a number of issues. The other issues Eastern Cape has covered, and I do not want to belabor the issues, but all we're trying to do is to get ready to be able to provide the healthcare that is required over and avoid paying the fee, the settlements that are this huge. So that's the first part that I wanted to deal with, and we're already planning to convene a litigation strategic dialogue, and we're looking at convening that event around August this year. The issue of servicing clients or patients from Lesotho has been raised. And I just want to explain it on two fronts. Firstly, we have patients or clients that come from Lesotho that are referred to us through the recognized channels. And there is a specific hospital in Lesotho that make referrals, and we are able to bill and to a certain extent receive revenue from the services that we provide on that side. But there's patients who do not follow the proper referral system, those who are in the country without illegally, and those also come to our facilities, and we get to service them. And unfortunately, those we are not able to recover the cost, because our MOU with Lesotho government indicates that only those that come through proper channels, that they will accept liability for the invoices. But it's something that we're planning to undertake and find a solution to. But this also goes on for other, undocumented nationals who are in our country and in our province. A similar situation goes for it. But in terms of the numbers that are on the HPRS system, Ndade Ntombela will deal with that matter. There is a mention about availability of chronic medication in some of our facilities. This matter, we picked it up very early as it was beginning to surface, and our team moved swiftly to address that problem. And within a very short space of time, our dashboard was indicating that all our facilities were equipped and stocked with medication, and our stock availability was ranging above 90%. I am available and willing to engage in places where there are outliers in relation to this issue. But this was a localized problem in Fezile district, and the team moved swiftly to deal with that situation. In terms of the HPRS and Impilo, I think the only challenge that we're facing is the communication between the two systems. But I think we'll deal with this matter at another platform, because when a patient comes at the clinic and when he's referred to the hospital, the two systems at this point in time, the communication between the two systems, I have not been assured of, and I think is something that we need to be looking into, so that we can be able to track and trace our patient right through our whole health system, and the records be kept, be kept accurately right through the system. The final issue that I just want to talk to Chair is that we would maybe request that we be guided in terms of the oversight visits that are performed by members in our facilities, as this at some point creates some challenges, but I think we'll be guided in terms of the processes that have to be followed, so that there's acknowledgement that there will be oversight, and the management of the facilities are informed about this, because we've received quite a number of reports about members of the national houses and the provincial houses just arriving in facilities, and the staff being busy, but because the honorable members are there, they have to be given attention, and that to a certain extent disrupted our the flow of our clients in those facilities. Honorable Chair, I'll leave the the other parts of the questions to Ndate Ntombela and Ndate Chris to respond to, as well as the HOD. Thank you very much, Honorable Member, with your permission.
No, thank you, Honorable Chair and Honorable Members, and thank you, MEC. I just want to, my name is Moses Moremi, I'm the Chief Financial Officer. I just want to emphasize 2 points on what the MEC has said. With regard to the Thusanong Clinic in Kronstadt, that is closed due to infrastructure challenges. I think MEC has indicated that we can give a separate report on that. There is a clinic which is nearby called Lesedi Clinic, and patients that are supposed to be treated at Thusano are now being treated at Lesedi Clinic. So far, we haven't received any complaints from the community there in terms of redirecting patients to Lesedi. The second clinic was the Noord-Nagel, which is in Clocolan, which is also was closed due to infrastructure challenges. But currently, patients are now treated at Mamelo CHC. Mamelo is actually a big facility, community health center. So patients is Mamelo and Kokelo, because those are the 2 clinics that are very close to Noord-Nagel. They're actually less than 1 kilometer from Noord-Nagel. And there was an engagement with the councillors there so that they are aware of the challenges that we have in there in terms of infrastructure. So far, we haven't received any complaints, and patients are treated at those 2 clinics, Mamelo and Kokelo, in Makwat for the closed Noord-Nagel clinic. Over to my colleagues on other issues. Thank you, Chair.
Chair, Bandile Ntombela again, Chair. Honorable Du Plessis raised the issue of the cross-province data systems. The Honorable MEC has already addressed the challenges around interoperability of the existing systems. Now, that's quite correct, Chair. The HPRS, as well as e-Impilo, that are developed by the National Department of Health, are organically built to be to operate across provincial borders. So the HPRS is widely operated, as you would have heard, and at some point, e-Impilo will be same. The challenge of interoperability, that is the communicating with the existing systems, is something that we are progressively working on. Like the Eastern Cape, we too are using the HMS2 system in our district hospitals. As a matter of fact, it is through the work they did and our collaboration with the Eastern Cape Department of Health specifically that we are now also rolling out HMS2 currently at 15 hospitals. So in theory, Chairperson, with a bit of deduplication, we can track patients that are visiting hospitals that are using HMS2 in the Free State as well as Eastern Cape at this point in time. The Honourable also raised the issue around connectivity, and I thought Dr. Wagner from the Eastern Cape did handle the issue quite extensively. So we started working on scaling up our connectivity as far back as 2014 with the NHI pilot. I think it became very clear when the bill came out that the dependency on the NHI data system was going to be, quite important. So we then progressively started rolling out connectivity mostly to our clinics. We do not have so much of an issue with connectivity in hospitals because the State Information Technology Agency does provide reliable connectivity there, albeit costly. With our clinics, we're using various solutions such as collaborations with the mobile network operators as well as the entities from the Department of Communications and Telecoms, Broadband Infraco. Honorable Feni raised what I thought is quite an important issue around what value are we getting out of the HPRS insofar as the rurality of our province is concerned. And I think post the deployment of the HPRS, I'll mention but a few. Our medical legal investigations are a bit easier in that we are able to track the first encounter of the patient at primary health care, and that data is then used in the investigations. Where all of the facilities that are implementing HPRS the time it takes to retrieve a patient file, which is paper-based at this point in time, has shortened significantly because of the numbering that is linked to what is on the system. We also are using the electronic appointment system that is inherently part of the HPRS, but we do recognize that not all facilities are currently using the electronic appointment system, as some are still using the paper-based. But this is an ongoing continuous change management exercise that will continue to assist our facilities in order for them to migrate to the electronic system. Honorable Brett raised a number of issues around network infrastructure and connectivity, and I think the work that we've done with SETA as well as the entities of the Department of Communications has also catapulted us. As of recently, the MNOs have been busy, assisting with connectivity through a project called the Social Obligations. This is just the agreement that that was agreed to when the spectrum was sold, that they will assist to connect public clinics. So where we do not have connectivity, we've been working with all three MNOs at this point in time to provide connectivity at those clinics. I've touched on the issue of the booking system, which is not widely used as it could be. And I think it is continuous change management, including engaging the public themselves, and that because we've historically found that even when we do appointments, the culture of adhering to the booking times is still not quite there. So this does require the involvement of our clinic committees and all of the stakeholders really that operate in our catchment areas. And then as far as the digitization of paper-based records are concerned, there have been a number of initiatives that we undertaking to move us in that direction. Within the limitations of our budget, we are back scanning critical paper records, especially those that give the highest medical legal exposure, in particular the maternal cases. We've worked to digitize those from paper-based to digital formats that can be used in a court setting. And as far as the digitization of current patient records are concerned, like I've said, and like Dr. Wagner has emphasized, that we're rolling out HMS2 with the view of moving to digital first, where we capture all of the administrative as well as the clinical data on the system at the visit of the patient. Honorable Kwele raised the issue of the work that we're doing with the DCDT. I've touched on the social obligations project, but as well as South Africa Connect 2. South Africa Connect 2 is essentially the South African broadband policy, where the DCDT as well as SETA, Broadband Infraco, and other entities are working together to provide connectivity, mostly at areas that are critical to the direction of the country, health and education and what have you. So we do benefit from that project as well, which has helped us to connect a few of our hospitals through that. The issue of power outage is quite a concern. I agree. I think Honorable Arendse is quite correct. This at some point in time when we still had load shedding, this was probably our biggest threat to our digitization effort. But the department in the province has worked quite aggressively in terms of providing generators and UPSs at some of our clinics to make sure we do at least provide some level of support in the absence of the primary electricity supply. And then as far as disaster recovery and business continuity are concerned, the HPRS is backed up by the CSIR, and there is a secondary site where data which is essentially a hot site, where data is continuously being backed up in the event that the primary site faces challenges. So at this point in time, we are able to guarantee no less than 95% of uptime insofar as the HPRS is concerned. Dr. Wagner mentioned that the HMS2 operates in a cloud environment, so that is 99% availability in access of the HMS2. But I think as a matter of principle, Honorable Arendse, the eradication of paper-based file system in not just the Free State, but in the country, I think we all appreciate that it is a very resource-intensive process. It would also take us a bit of time. But I think, if you look at the efforts that have been made in the last 5 years, as far as the use of the HPRS to make sure that we are able to account for every user of our public health system, as well as the downscaling of commercial systems in public health that cost us a lot of money and don't necessarily deliver the value. The adoption of systems such as HMS2, the HPRS, and now Impilo are going to really catapult us into being a bit more aggressive in using digital systems to manage patients. And of course, with that will come the issue of interoperability as well, where systems speak to one another. The Department of Health nationally, as well as the CSIR, as a matter of fact, hosting what they call the Projectathon in October, which will address some of the challenges specifically around how systems in health, both private and public, can share data in a safe way to allow us to manage our population much, much better. And then lastly, I will then talk about a point that the Honorable Chair herself made around duplicate entries or possible duplicate entries in HPRS. Quite correct, Chair. Those do exist because the HPRS has got an offline capability. Now, instances where, for whatever reason, facilities struggle with internet connectivity, they are able to continue using the HPRS, and then when connectivity is restored, they then synchronize with the central server. So when such challenges arise, inadvertently, there will be duplicate entries as patients visit facilities across the province. But the Department of Health nationally does do regular deduplication exercises in the background to clean up the databases and remove those duplicate files. Thank you very much, Chair. I will then hand over to my colleague, Dr. Chris, to handle the audit issues.
Thank you very much, Honourable Chairperson, Honourable Committee members. Just regards to the specific questions regarding the Free State's audit matters. The first one from Honourable Sibande, just regarding the historical value and how it is not supported. So what the department was able to do is we were able to go itemize specific payments per project dating back for the last 10 years. So those are supported, we are happy with. The risk came about when you start looking at projects as far back as 2007. So what we did there to manage those risks is we looked at the evaluations and the processes followed by Public Works on the improvements of those facilities. And so obviously it's values that they have capitalized within their registers already historically, and we used and we piggybacked off those processes to determine the values of the projects that would have taken place at the time. We also looked at alternative support. So this would have been project closeout reports or a completion certificate within the engineering sector. So for us, the challenge of not having detailed payments listed due to the historical data, we found alternative ways to try and mitigate that challenge with alternative support. In terms of the classification of expenditure, so the challenge arose where historically the department was putting all its infrastructure budget as capital budget. So all the work that was done, irrelevant of the type of work, was just being budgeted for and paid for as capital improvements. But when we went through the identification of the projects and the detail of the actual work being done on the ground, we realized that we're actually sitting with majority of our work that is repairs and maintenance related. So we're actually just maintaining what we have, and we're not really improving facilities by adding extra wings or building new facilities. So that led to a complete reclassification of a lot of the projects and the expenditure that we sat with historically. This was obviously then, from a financial statement point of view, led to a prior period error and a big reclassification around that. And in total, we have then submitted that revised register to the Auditor-General, which they are currently auditing on our side. With regards to the questions from Honourable Aris, just around the compliance of procurement and the fraud risk, The Free State Department hasn't received any material non-compliance in the last 2 financial years with regards to procurement. So what happened and led to that was that we took the historical findings of the Auditor-General as well as internal audit, and we improved the control environment, the checklists, and so forth within the procurement space, just to strengthen the controls around that to ensure that we do have compliance, and that seems to be heeding the results that we wanted. And additional to that, when the HOD joined, she also started a process of probity audits, where once the procurement process for a provincial tender has taken place, we run a probity audit on that tender before it is awarded. So this then just gives a bit more comfort around the compliance processes around those tenders, as well as ensuring that the fraud risks are mitigated. And then just with regards to consequence management, majority of the consequence management is linked to the historical irregular and unauthorized expenditure that has taken place at the department. A lot of this we've put in an action plan to try and deal with in terms of the investigations themselves, but that does lead to a capacity issue. To address that, we have approached our provincial treasury to see if there isn't a spare capacity that can assist us to fast track those processes. Provincial Treasury is currently in a process of going through a framework contract to try and source the necessary skills for the province so that we can address that. But subsequent to that, with the limited capacity that we do have, we are preparing the determination tests and the investigation reports for the historical challenges where we can. Those are then filtering through the HOD's office to Labour Relations, where disciplinary cases and so forth are ongoing. So yes, we haven't 100% resolved that yet, but we've got a plan in place, and hopefully with Provincial Treasury's assistance, we can resolve that a lot sooner in this financial year. Honourable Chairperson, committee members, I think we've managed to cover the remaining questions that were directed to the Free State. Thank you.
Thank you very much, CFO. So now I give over to the Western Cape. Honourable Minister of the Western Cape.
Thank you very much, Chair. I will take the first opportunity to answer as many of the questions as I can, and then I will hand over to the colleagues. Let's see. So there was a question around, the link between, how the data systems support or what kind of impact they have on the burden of disease. And that is, that's quite hard to do. And I suppose some empirical studies would have to be done. But of course, what they do is to strengthen the health system generally, which helps us to deliver better quality healthcare overall. So the importance of these data systems cannot be underestimated. I suppose it's also important to remind the honourable members that although the Western Cape is an urbanised province, we also have very large rural areas and, that are quite far away from the metro, if you think of the Karoo and the Kawabokaveld and so on. So we similarly have clinics in sort of deep rural areas as well as peri-urban areas. But I would like to assure the honourable members that in spite of these, all of our primary healthcare clinics are connected to broadband to enable the use of these IT systems. There were some questions on the medico-legal, which I'll ask the colleagues to delve into, but suffice to say that we do have a multidisciplinary team, which includes, of course, the lawyers, the legal team, the Office of the State Attorney, and then we also include clinicians in our teams, which helps us to have an all-round view of the cases and how we could navigate them. We also have ongoing training webinars for all our staff members, and our unit also has an open line to hospital staff if they are seeking any advice on any of these matters. Then let me just see, there was a comment on Puckelsdorp. The Puckelsdorp clinic in the Garden Route is, yes, the honourable member is correct, is due for an upgrade. This is being navigated by the National Department of Health through the NHI indirect grant. So it's not anything that we have control over. It is a nationally run project, and the National Department is currently in a legal dispute with the implementer. And this is the reason why there are significant delays in this project, as well as a few others that fall under that same umbrella. And we don't know what the timelines are for that dispute to be resolved, and so that that upgrade can finally be done. There was a question on when we can get everything online. I think that's a very good question. I think this would be budget dependent, and under the constraints that we currently have, the timeline is quite hard to give an exact date, but it is certainly something that we're all working towards. With that, I'll ask the colleagues to jump in. There was a question on the name of the hospital that is not currently connected and when that will be connected. The medico-legal team. Oh yes, our systems and whether they can work offline, I beg your pardon. And then I think that's all of us done. Dr. Karim, can I hand over to you?
Thanks, Minister. Yes, let me follow up on some of the points. I think perhaps just to start off also with the Honourable Member Sibandi's question about migrant workers. So yes, obviously, so that's quite important for us as a province, obviously, and particularly with regard to the agricultural sector, because the migrant workers would obviously add patient numbers to the PMI. And we did mention in the presentation that integration with Home Affairs data is quite important. We've also been working with our local farmers in the area, so that's also quite an important project, because often we find that the farmers are prepared to provide some sort of services on their farms, and then we work in collaboration with the farmers, particularly the big co-ops in some of the rural areas that we've got, and apple picking, etc. The big farmers in those areas. And then we will provide, for example, the medication, and the farm owners would provide, for example, the clinical care, the nursing care in particular. We did also, I think there was a question also that member asked about the foreign nationals. It's a difficult area. We obviously encourage all people to come. When they come to our clinics, we obviously will ensure that we provide services. We did, for example, during COVID, we had a specific project of making sure that we provide vaccination to foreign nationals, because we know that they're actually scared to come to our clinic services because they're going to be asked for an ID, etc. So sometimes we work with the NPOs in that space. And so during COVID, for example, we had a really good project where we vaccinated foreign nationals at places where they congregate, where they prefer to go to. But if anybody does come into our service, we obviously will ensure that we provide services to them. Nelspruit, as Minister asked me just to comment on that, it is a transitional care facility. We are working with .P. The whole of the area around Nelspruit has a connectivity issue. And so that is actually the problem, but we are working with .P in terms of trying to connect the whole of the area of Nelspruit. We're hoping to complete that during this financial cycle. Honourable Member Du Plessis asked about, and Minister was also talking now about the visibility across the whole of the system. So that's quite an important aspect. So what we're talking about now is really crucial to providing, as Minister said, strengthening the health system from a clinical care perspective. So if I can give an example. So we've got, for example, developed these line lists of all our TB patients and all our HIV patients. We call them HTEL for HIV and TTEL for TB. And so what we've done with that is we're making sure that every local geographic area, that the clinic team in that area has full visibility of all the patients, for example, who have TB who are in that area. And obviously then we can monitor if people fall out of care, and we can send our community health worker team out to bring people back into care. And so that's obviously quite important. I mentioned, for example, another example I mentioned earlier was the NHLS and EMS cyber attacks that we've had. And what we did there, for example, we were able to build a direct pipeline from the machines that do the testing into our single patient viewer system, so that our clinicians had continuous sight and visibility of the patient data. So as you quite rightly point out, and as Minister also said, now it's quite important that we have data visibility right across the whole of the system, and that obviously strengthens our system. You also asked about medical legal. My colleague Anda will speak a little bit more to that, but Minister mentioned the multidisciplinary team that we've got, and it really is a very good team. And the training that we do includes, for example, clinical training. We know that, for example, in obstetrics, obstetric emergencies are often one of the challenging areas where the biggest proportion of cases are loaded. And we've done some training with our clinicians in that space as well. Pakkelstrom Minister answered about Pakkelstrom. I think member the answer was also asking about safeguarding patient files and duplication of files. I'm going to ask Noble Kosi if you don't mind on picking up on that one, but that is obviously quite important. And our services are busy with projects where they're trying to sanitize the folder system, for example, make sure that they remove duplicate folders, or that they, that we don't have patients coming in and opening new folders all of the time. You also asked about electronic record and when. That's the ultimate goal, is to have an electronic record. The architecture that Ms. Lamini presented gives an example of the different systems that are in operation, and it is our intention to obviously bring all of that together. We've done with the establishment of a provincial health data center. We already gone very far in being able to have visibility across the systems in our single patient viewer. But it does depend on a number of dependencies like connectivity, working with CETA, obviously it's budget dependent, and then supporting interoperability across the systems is obviously quite crucial. With regard to power and load shedding, yes, all our facilities, hospitals, clinics have generators. But over and above that, some of the newest systems that are being installed have offline capability. But we are also very busy with an active project around installing hybrid inverters and solar photovoltaic panels at our big hospitals. So, for example, for this year already, we've already done Paarl Hospital and Hermanus Hospital. And we intend doing Red Cross Hospital as well, and Muscle Bay Hospital that are in process at the moment. And the plan for the rest of this financial year would be to cover 12 hospitals with these PV panels. And that will obviously allow us to utilize solar power more efficiently. And so we've actually got quite an active race to net zero project, trying to make sure that all our facilities, as far as possible, have solar energy and solar power, both in the metro and in the rural. I think there was a question, and just a couple of general comments, and then I'll hand over to my colleagues. Just obviously in terms of service pressures, and post-filling. I mean, our post-filling rate currently is at 97%, but obviously it does depend upon the budget that's available and the availability of staff. One particular area that I'm sure most provinces would be struggling with is the nursing area for scarce resources. These are the specialized nursing colleagues who, just finding them is already a challenge. But we have a very active post-filling rate. Our colleagues that fall under Mr. K, as well as our service colleagues, work very closely together and very actively together in managing the posts and making sure that we prioritize posts and fill them as soon as we can. General comment about the interoperability, as many of my colleagues have said, I mean, that's quite an important issue, making sure that all of these systems are interoperable with each other allows us to be able to move faster towards that electronic record, patient health record that we're talking about. And just to close from my side, it's also important, our patient-facing interface, for example, we really do feel that that's going to be quite a game changer as well. So it would allow patients to provide, for example, a private GP. If they go to a private GP and they give the GP permission, we're working on the project to then allow that private GP to have insight into that named patient's data that we've got. And as you've heard from Ms. Lamini, we've got a very rich database spanning many years of individual patients who have been in our facility. So if I, for example, go in, type in, for argument's sake, my details, then the clinicians would have visibility of the visits that I've had in the public sector, the access to the NHLS results, etc. So that patient-facing interface is also quite an exciting project. But let me ask Anda to comment on medical legal. Anda, you might want to say a word or two on that. And Ms. Lamini, if you want to maybe comment on the connectivity and safeguarding patient data. Minister, is that all right with you?
Yes, please go ahead.
Anda.
Thank you very much. Thank you very much, Minister, and good afternoon to the chair and members. Ms. Anda Ngosi, I'm the head of strategy, and the medical legal unit resides in my component. I'm going to switch off my camera now, Honorable Chair, with your permission. Just touching on the issue of medical legal claims, I can report that indeed, as the province, we have a fully fledged medical legal unit which resides within the Chief Directorate Strategy under the Directorate Assurance. It is a multidisciplinary team. Internally, the team is made mostly of the clinical staff. We've got 3 medical officers, 2 senior admin officers, and a clerk. But we also have good collaboration and partnership with legal services in the Department of the Premier, and also then with the State Attorney by extension. And the unit has been set up as far back as early 2000s by Dr. Bass. So we have matured the unit over the years and have learned from experiences of, having dealt with medical legal claims at those initial stages up to where we find ourselves now. And really, we focus mostly on the vigorous defense of cases where we can prove that we are on the right. But also we proactively engage in tendering of services before we can settle on a lot of these cases, which helps then to reduce the lump sums that need to be paid out. And we use every opportunity to feed back to the services so that we can ultimately improve the quality of services provided to prevent future medical legal claims in the future. But also the approach that we use, which has been quite helpful, is how we approach this from the center, being now the unit at the head office, how we relate with clinicians across the platform, that we don't follow a punitive approach, but rather an approach of wanting to learn together from medical legal cases, because we assume that nobody goes out there to want to intentionally harm patients that come to the system. So we use then the opportunity not to punish clinicians for medical legal cases, but to learn from those and see what elements of the system need to be strengthened to improve and prevent medical legal claims going forward. So it's really a working model, and it has helped us as the province to significantly reduce the lump sum payments that we then make out in the form of medical legal claims. Thank you very much, Chair, and I think my colleague then, Nobukosi, will close off with aspects remaining on IT. Thanks.
Thank you, Anda, and thanks, Minister. Honorable members, I think the Minister and Dr. Karim have addressed the issue of connectivity. We do have, as the Minister has indicated, connectivity to all our facilities, but also, as has already been mentioned, in the rural areas. Also noting the issue of Nelspruit, the issue there is that the network providers have not yet gone to invest in putting the infrastructure in place for us to have that good quality of connectivity. Nonetheless, there are other forms of connectivity that we implement, such as satellite connectivity, microwave connectivity, and so on. It's just the quality then is not the same as what would be experienced in the urban areas, but we do try our best to find solutions to assist and ensure that connectivity is strengthened in those areas. I think also Dr. Karim has spoken to the offline capability of our systems. So our newer systems are being built to have offline capture, that then when the systems are back online in the incident of load shedding, that data then replicates back to the central database, so that the work doesn't stop if the system is offline. Also, some of our systems then also allow staff to continue capturing information on the patient folder, and then if there's an issue with connectivity, they could capture the information after the fact, after the patient visit. I'll also speak around safeguarding the data and duplication of folders. So when we have some ways of identifying when the folders are scanned into what we call our electronic content management system, we have some ways of identifying if a record is a potential duplicate, and we flag it so we don't merge it immediately. But we just highlight that it's a potential duplicate, and that is only confirmed when the patient is actually standing in front of the admin at the facility to confirm that this is indeed their details. So then we are able to then combine those duplicates into a single record. But the win for us will be to implement the biometric solution that we've been mentioning. Then in terms of just safeguarding the data in our electronic environment, we have a number of policies and measures in place to safeguard the data. So we have data governance policies and standards that we use for data protection, use, and retention. All our data in all the systems is encrypted at rest. So where it's stored and encrypted, and in transit as well, when it's moved from one format to another system. We have access control in place on the network across the provincial government. And when, for example, a staff member joins, there's an approval process that goes where a senior staff member, supervisor, or head of the unit will then authorize for that person to be granted access to specific systems that they need for their job role. When it comes to authentication, we have policies around authentication, where on the network, for all systems on the network, we use what's called multi-factor authentication, which is a security measure that ensures that we check that the person who's trying to access the data really is who they say they are, and also that they have the necessary authorization to access the type of information that they want to access. All our systems also maintain a data audit trail for data access and modifications, so we can always see who accessed what data and who updated a record, for example. We have vulnerability scans that run on the network, which are able to highlight if there are any security threats that are identified, and then that's escalated to the relevant systems manager for them to address those and eliminate the vulnerability. We also have across the province staff training on security policies and how to identify any threats to security, and how to identify any attacks, fraudulent attacks, things such as phishing emails, and so social engineering and so on. So those are a combined interventions that we have to ensure that we safeguard the data both on the network level, but also at the systems level where it's captured and stored. Thank you very much. Back to you, Minister.
Thank you very much. Chair, I think that's all the questions responded to, hopefully.
Thank you very much, Honorable Minister from the Western Cape. I just want to thank the MECs as well as the teams from the different departments for their responses. If there is any questions that is not, Honorable Fanny, your hand is up, or is it a legacy hand?
No, pardon me, Chairperson. There is an issue that I've raised on the chat. Will it please be also attended to because I forgot. I think it's 2 questions. I won't delve on them now. For just for your attention, Chair, and also for processing them, Chair, please.
Thank you, Honorable Fanny. We will, Honorable MECs and the teams, if there is any questions that you did not respond to, or like the Honorable Fanny has indicated, as well as Honorable Baines, because of her connectivity, she couldn't speak and could not do a question. So we will, through our office, communicate with the department to give them the questions that is not responded to, as well as the ones from Honorable Fanny and Honorable Baines. And we will request the departments to please respond within 7 days after receiving the questions. And then from my side, I just want to indicate to the MEC of the Free State in terms of the oversight visits from the honorable members of Parliament. Honorable MEC, there are 2 kinds of visits, unannounced and announced visits. With the announced visits, we do our planning and we also follow procedures and protocols. In terms of the unannounced visits, as a member, you can do an unannounced visit, but at that visits, you just have to observe. You cannot expect the personnel to attend to you or to even demand any information when doing unannounced visits, Honorable MEC. And then I will only request the department, if you can please provide us with a list of the different facilities in your province. And with this list or template, can you please indicate which facilities is fully functioning in terms of the HPR system, and if there is facilities that is not fully functional, can you please indicate what are the challenges in terms of this facilities? And in this same template, can you also indicate to the committee in terms of the cost, what it will, the estimate? We know you can't give us the exact cost, but you can give us an estimated cost in terms of this challenges of what it will cost to rectify these challenges. So, Honorable MECs, as well as the teams from the different departments, I just want to thank you for your presentations, as well as the responses in terms of the questions. We really, as a select committee of social services, we really appreciate your time that you have take out of your busy schedules to come and present to the committee. You are excused from the meeting. You may leave now, because as a committee, we still have some issues to deal with. Thank you very much, Honorable MECs, as well as the teams from the different departments.
Thank you,
Much
Chair.
appreciated, Honorable Chair. Thank you.
Honourable Chair, thank you, honourable members.
Honorable members, the minutes of the 18th June is in front of us. Can I get a mover for adoption of those minutes? Honorable Adria Hansen, move, and Honorable Sibande, second. Thank you very much, honorable members. This meeting stands adjourned.
Amanda.
Thank you, Chairperson.
Thank you very much, honorable members.
Lekker dag, Chairperson.
Lekker dag vir u ook, honorable Sibande.